from UJT, from the University of Rwanda. I would like to welcome also all our colleagues from different parts of the country, surgeons, surgical trainees, nurses that we work closely with. To all of you, you are more than welcome, and we hope that the theme of this conference will call all of us, as it is most concerning for the future of surgery. So, without further ado, as we took some time, I'd like to welcome the president of the Rwanda Surgical Society to give the opening remarks and welcome the whole team. Professor Ngusi.
Good morning. The guest of honor, the ES HRH, who's representing Minister of Health, distinguished guests, ladies and gentlemen, and thank you for coming. I start with apologizing for starting late. We are late, not because of our making, but most of you saw what was happening, so that led to this late starting. We promise that we going to catch up as time goes on. Let me take this opportunity to thank all partners, the Ministry of Health, RBC, the NIH Hub, and all other partners that supported this event to take place. Thank you very much. I also take this opportunity to thank the executive committee that has worked through these tough times to make the society keep on moving. I thank you very much from the bottom of my heart. Without you, we wouldn't have, the society really wouldn't be where it is today. As going to see, we have achieved a lot, though not in physical contact. We have achieved a lot. My address today, much of it is a repetition of last night. So what I'll do, I'll avoid, as I said, I've thanked all of you for coming. I thanked our partners. Thanked all members for coming to participate. I welcome students, all university students that have come to attend, which shows that they have interest in becoming surgeons. So I welcome you to the surgical family. What I will do is to not repeat my speech of last night, but to immediately invite the guest of honor to come and give us what he prepared for us today. Guest of honor, you are welcome.
Thank you, Professor Ngusi. President of the Rwanda Surgical Society, distinguished academician, dear colleagues in the health sector, partners in the National Surgery, Anesthesiology and Obstetric Plan, dear students, ladies and gentlemen, good morning. It gives me a great pleasure to stand here today at the auspicious occasion of this 12th conference of the Rwanda Surgical Society. Surgery is an indispensable part of healthcare, and there is now global recognition that health systems planning is incomplete if the surgical system is left unaddressed. Surgery procedures need a special level of meticulousness and ethics to bring about successful results for the patients. It not only ensures patient safety, but also saves their lives. Access to safe surgery is a national and global priority, and it will greatly contribute to the UN SDG 3 of attaining a good, healthy life and well-being for all people of all ages. In the past year alone, Rwanda has recorded more than 172,000 cases that required surgery, either major or minor. Over the last 3 years, SAO providers' density has grown from 11 to 13 per 1,000 population, while surgery cases have grown by 7%. Despite the high demand of qualified health professionals necessary for safe surgery, specialists, subspecialists, nurses, anesthesiologists, and so on, who make up a multidisciplinary surgery team and are skilled to adequately respond to such needs in Rwanda, the numbers are still very scarce. In addition, interested candidates to further pursue surgery specialty and subspecialty is remarkably low. I was telling my colleagues that we launched a call for application to train a cardiothoracic surgeon, and we didn't get any. So if you know people in your networks who are interested, the call is still out there. Despite incremental positive changes over the years, the current SAO trajectory is inadequate to realize the 2030 access goals. Increased training and retention of specialists are necessary to address the critical deficits of SAO providers. To meet the increasing demand of surgical care, the Ministry of Health has taken important steps to advocate for and improve the surgical services by expanding infrastructure and the staffing. There is a surgical ward that will be completed at Kabgayi somewhere early next year that will have 120 beds. Additionally, the Ministry of Health, through various stakeholders, supports the development of the workforce that will contribute to building more sustainable surgery training programs and develop the cadres who will provide quality services. This year, the University of Rwanda started 3 new training programs related to surgery: the pediatric surgery program, the plastic surgery, and gynecology programs. And we are planning for more trainings in the near future. However, given the gap facing the country and the present needs, it's critically important for all surgery professionals to join forces in doing all the possible outreach and advocacy necessary to create a surgery system that is fit to meet all the needs of the country. And we appreciate a lot the outreach campaigns that are done on a regular basis to be able to meet the needs of the people across the country. So there's still need to train more surgeons and the teams of cadres involved in surgery. The last 2 years have been challenging as the COVID-19 pandemic has put extreme stress on the healthcare workforce globally and in Rwanda, emphasizing the surgical workforce shortages and maldistribution, as well as increasing healthcare workers' exhaustion. We are particularly fortunate today that we have among us various key surgery trailblazers, mentors and advocates in the country who are pivotal in improving the quality of the future of surgery, and other leaders who have contributed in availing and advancing quality surgery services in Rwanda. And I want to remind you all that although the journey is still very long, we are all moving in the right direction. As surgeons, you all have many facets. You are clinicians, you are lecturers, you are mentors, you are researchers. It is therefore important that you continue to conduct research, to better understand the challenges that we face, to generate new evidence, to improve the care of the patients, and bring about innovations in the way we do business. The Ministry of Health is counting on all the faculty, leaders, and professionals here present today to become ambassadors of accessible, safe surgery and mobilize all the possible resources necessary to create a sustainable capacity building for surgery professionals. And we welcome new ideas that will help improve our services and our training programs. Before concluding these remarks, I want to express my gratitude to each and every one of you for your commitment to be here on a Saturday morning and for your efforts that went into the preparation of this conference. I want to appreciate all the surgeons for all the work that you do day in, day out in your different facility. Much appreciation, therefore, for the organizing committee to gather us all here today. I also very thankful to the speakers. We are happy that this conference is serving as a great platform for conversation and experience sharing that will shape surgery personnel training and ultimately evolve the quality of surgery services that we want in Rwanda and in the region. I urge us all to use our voices to promote this worthy and immensely rewarding profession. I wish you a very fruitful conference. Thank you.
Thank you so much, Dr. Ndimuwanzi, the Executive Secretary of HRH at Ministry of Health. Thank you very much for those opening remarks also from the Rwanda Surgical Society, Professor Ngusi. I forgot to present myself, and I realize I'm a very bad host. My name is Gasakure Miguel, and I also hold a PhD in time management, and I'm a professional clapper. I'm still recruiting, and I would like another round of applause, please, for the presenters. So, as we said, we are gathered here to try and focus on the solutions regarding surgical education. And it's a problem that concerns all of us, not only the mentors that we have here, not only the stakeholders, but also the trainees as well as the nursing team. So I am very privileged to start the session with a panel of I would say most of the mentors of the surgical trainees and myself here. I would like to welcome, and I hope that I will get more applause from the audience. We would like to welcome someone who has been at the core of surgical education for now more than 40 years and has started a lot of programs. He was at the time also the rector of the University of Rwanda. Please help me welcoming Professor Emile Rwamasirabo. Yes, you are more than welcome on the stage. So, and the next is also currently helping in different surgical education and as well as new programs, new curriculums. He is also mentoring a lot of students, and he is currently the chair of the Department of Surgery at CMHS, the College of Medicine in UR at the University of Rwanda, and he is also the director of the research hub that is currently promoting this conference. Please help me welcome Professor Faustin Nirenganya. So we also have, as I said, we are still focused on surgical education, and he is one of the mentors and starters of the pioneers about primary trauma course in Rwanda. He has been the head of department of surgery at CHK. Please help me welcome Dr. George Nakiruta. And last but not least, coming up from the north, very far north, from the coldness, he came multiple times to teach, to help differently, be it through WhatsApp or even in person. He is currently the Dean of Medicine at UGHE. Please help me welcome Professor Abebe Bekele. So, I think the bar is set very high in terms of presenters, and I guess the different presentation will be very interesting. We hope to have a good discussion, and I will be the moderator for this session. And as I said, the time management is my thing. So we'll start with Professor Rwamasirabo. We'll have the presentation on the board. Thank you.
Good morning, the guest of honor, the Rwanda Surgical Society president and executive, dear colleagues. I've been requested to give a brief history of surgical training in Rwanda. Of course, it's going to be a very brief overview of where we're coming from and where we are. Can you? Yes. So as you remember, Rwanda became independent in 1962. In 60 years, we have 151 trained surgeons, all specialties combined. This is about, on average, one surgeon for about 100,000 people. Do not confuse this with the NSOP targets that looks at not only surgeons, but also obstetricians, anesthesiologists. So that's why one surgeon for 100 people is not equivalent to NSOP target. So what we have to remember is that between up to 1996, we did not have any postgraduate program in Rwanda at the then National University of Rwanda. That means 30 years after independence. So we have a serious gap there. Many of the universities in the region that opened even after our university started training postgraduates shortly after independence. So the fact that we spent 30 years without training postgraduate education definitely explains why we have this gap in the numbers of postgraduate, of specialists trained in Rwanda. Next. So here I just want to highlight the different steps towards the training of surgeons in Rwanda. In 1995, as far as I can remember, there were about 4 surgeons in Rwanda, 4 trained surgeons. Some surgery was being carried out by lots of people, including experienced GP, some NGOs, because that was a humanitarian crisis. We had NGOs that organized surgical missions to deal with casualties after the genocide against the Tutsi. But the question was, for some of us that were here, including also, of course, the Minister of Health, how do we get the surgeons? We had plenty of patients, plenty of casualties, also plenty of elective cases. How do we get surgeons? So obviously, one option is to send doctors, young doctors, to go for postgraduate abroad, but this is something that was not responding to immediate needs, because these trainees would be going for many, many years outside the country. They would not contribute to immediate needs. So surgeons from the diaspora, lots of people came back from diaspora, but surgeons were not very many in the diaspora neither. So we thought of starting to train surgeons locally. The issue was, who's going to train them? Because we didn't have trainers as well. We have very, very few. Who's going to train them? Which training institution? Because the university, that time, did not have a postgraduate program. So 1996, 97, the then National University of Rwanda, the CHK, the Belgian Corporation, and Belgian universities started, of course, with the Ministry of Health, because it is the ministry that was responsible for cooperation. We started a cohort training program for general surgery, obs and gyne, pediatric, and internal medicine. It was a sandwich program, 2 years in Rwanda, 2 years in Belgium, and Belgian university professors would be coming to Rwanda almost every month. That's how that program started, but this was a cohort program that went up to the year 2000. That's why many of the surgeons, the senior surgeons that you see around, started their training that time. 1996, 2000, we had a cohort of surgeons to South Africa. And many here, many that are very much involved in the training of surgeons are also here. We have Professor Husi, Professor Butera, and you can see Dr. Furaha here, and other colleagues. But of course, the numbers were not very many. And the local training program resumed in 2005. And many of the trainees of that time are here. This is the program that comes up to today. 2007, of course, we had the Rwanda Surgical Society that became also involved in the training. In 2008, Rwanda became member of the College of Surgeons of East, Central, and Southern Africa. 2013, we had the US-led HRH program that also gave a new impetus to the training and also the new specialty training, including orthopedics, neurosurgery, and urology in the country. And 2019, if I'm not mistaken, the new Minister of Health HRH program took up the strengthening of the existing institution and also the planning for new subspecialties. So in short, what we realize is that local training is the most efficient solution for meeting the needs of the population. Surgical training cannot be successful if surgeons are not organized and committed to teaching their young colleagues. This is very important. The Rwanda Surgical Society needs to be supported by surgeons first and foremost, and the MOH and the other stakeholders for effective contributions to the society. The Rwanda Surgical Society, through COSEXA, mainly had to become a regional, African, and international player by quality research production. This is, in nutshell, Mr. President, the few comments I had about the history of surgical training. Thank you.
Thank you very much, Professor Rwamasirabo, for this eye-opening about the history of surgery. We would like again to welcome once more the Rwanda Surgical Society President and current chair, the Professor Ngusi, who will be the main moderator for this panel. And we will then give the floor to Professor Nirenganya Faustin.
Thank you, Miguel. Actually, you are changing the game because this was supposed to be a presentation, not a panel. Now I'm going to get my computer. Can I stand here? Okay, thank you.
What we can do, we can move down, finish presentation, then during discussion, then we come up. Otherwise, those sitting here are missing a lot.
Thank you. Good morning, everyone. So, do apologize for that delay. So, I have been requested to talk a little bit about what we are doing at the University of Rwanda in terms of surgical training. So, it's always a privilege and an honor to come after Professor Rwamasirabo, and he highlighted well the historical background of all this. And he was there as a pioneer, and we trying to step in. So the next slide, please. The University of Rwanda is a public collegiate university, as you all know. So it was formed back in 2013 through a merger of the then high learning institution, which were public. So now it's the largest university in Rwanda, and we are counting so far around 40,000 students. So the College of Medicine and Health Sciences is one of the 6 colleges in the university, and we are part of the School of Medicine and Pharmacy, one of the schools in the College of Medicine. So we have 2 campuses. So the Remera campus, where the headquarters is, and then Huye campus, where the majority of our undergraduates, especially the basic sciences, are being taught. So we are having now around a little bit of more than 1,000 students in the undergraduate program, and we are able to enroll 150 students a year. Postgraduate speaking, we are growing big. So far we are counting around 37 postgraduate programs to the School of Medicine, accounting for more than 500 trainees. So this is okay, stay there. So the school has ramifications in the hospitals, because, as you know, medicine is essentially taught in hospitals, and we count now our major teaching hospitals, CHK, that you see in the far left, then the University Teaching Hospital of Butare, Rwanda Military Hospital, and King Faisal Hospital as the main university teaching hospitals. But we got recently the second level teaching hospitals, 7 of them across the country. So the teaching sites are increasing. Next slide, please. So this is the governance structure of the school. So now Prof. the Dean is here. He may be able to discuss this further. But I wanted just to highlight that from the university, the college, we have a school which has 19 departments. And among them, we have the Department of Surgery. So next, please. So the Department of Surgery that I'm chairing for now is the largest department in the school. So I think I will be agreeing with the dean on that statement. So we have 64 faculty now, and we have 10 programs. So we are the only department who is running more than around 10 programs. So among them, we have 1 undergraduate program that we share with the other departments, but also we have 9 specific surgery postgraduate programs. So we are now using 7 teaching sites, including the 4 university teaching hospitals and the 3 second-level teaching hospitals, as I mentioned. In the residence program we are offering now, we are offering general surgery, a 4-year program, ENT, a 4-year program, orthopedic surgery, a 5-year program, urology, a 5-year program, plastic and reconstructive surgery, a 5-year program, pediatric surgery, a 5-year program, and neurosurgery, a 6-year program. On top of the residences, we also run a number of fellowships. So far, we have 2 accredited fellowships through the university. So the minimally invasive surgery fellowship, which is a 2-year fellowship, and the pediatric surgery fellowship. In the pipeline, so this is the coming in a few days or a few months, we're looking to start a number of additional fellowships, including vascular, trauma and surgical critical care, thoracic, hepatobiliary and pancreatic, breast surgery, colorectal, and transplant surgery. And we have already started drafting a curriculum about ophthalmology residence program. So this is what we have in the Department of Surgery. So far, in terms of achievements, we achieved much. So we are happy now that through MOH, HRH, we have been able to recapture the faculty, and all the surgeons in the teaching hospitals, the majority of them are now on board as faculty. And we had a few months ago an MOU with the hospitals and the ministry on that end. So thank you for that. So that's the reason that I said I have 64 faculty by now. So we have been able to pass through the ASA audit and accreditation, and we passed quite well. And this was around the undergraduate program that we are running. So the postgraduate program is being audited soon. So I urge you to be as ready as we were for the undergraduates. So far, we have graduated around 100 surgeons. This is huge. And from 25, like Prof. Wamasira was saying, we graduated around 100 surgeons. So we now, as I speak, we have 62 residents in the training across the other programs that you saw in surgery. So our other achievement that I'm proud of is that when we submit our trainees to regional and international accreditation exams, like COSESA exams, they always, almost all of them pass. So far the pass rate in the COSESA exams for our graduates is above 90%, which is quite good. So we have been able to bring on board some international regional partnerships to support this program. And as we grow, we don't grow only in numbers, we grow also in equality, as we are now able to attract good grants to support what we do and publish a good number of papers in local, regional, international journals. So the way forward for us in the Department of Surgery, we think this is not like an individual adventure, it's a joint venture. So we think that we have to be engaged, all of us. We should not leave no one behind. We should be inclusive, and so that everyone who can contribute in this business is welcome. So we advocate that each surgical procedure should be a teaching or a learning opportunity. So please, surgeons, when you are operating, when you are in your outpatient clinics, be sure that you have students around you. So we also want to move out the traditional way of doing it. So far, we are only partnering with the public institutions. So it's a good opportunity also. We leverage the force which is now wise. So our private surgeons are also encouraged to join the education and teaching force, so that we can share their expertise, but also send the students them. So we want to increase the teaching sites and for all the programs. So as Prof. Wamasira was highlighting, they were 4 or 5 in 94. But now, as I speak, we are around 150. So Rwanda is having 150 surgeons by today. And then we cannot run the business as we used to do. So having a very 1 or 2 students. So we have to find ways to increase the number of intake and to diversify the sites in which we are teaching. However, we should be taking attention to keep adequate exposure for our students, so that the quantities that we are looking for are not overshadowing the quality which is needed for any surgeon and surgical programs. So I feel that we have a gap administratively, so the programs are not supported and not coordinated. So we are working on that so that we can provide administrative support to different programs. So this is my pledge and my wish that we as Rwanda Surgical Society and the surgical family, we have to drive surgical practice in Rwanda. So I don't see anyone who will do that for us. And this academic excellence, so we as surgeons, we should not only stay in the theaters doing procedures, we have also to get out of them do another additional work, which is actually at the end of the day, all of that is patient care. So there I mean research and advocacy. So I will probably extend a little bit on the last one, the advocacy part of it, because I think that now that the policy and the policy makers are joining us and understanding that surgery is very important, but we have to be with them when they make decisions so that we help them to understand better what we face as challenges and the best way to address them. So it's a job of surgeons to advocate for surgery. So I don't see anyone who else will do it for us. So those were the few slides I had to share with you. Thank you and have a good morning.
Thank you very much, Prof. Oste. Let's welcome Dr. George to tell us about COSEXA, and then we'll discuss later.
Good morning, everyone. I'm happy to be in front of you. I'm going to discuss or to present the surgical training through the College of Surgeons of East, Central, and Southern Africa. My name is Dr. George Ntakiruta. I am one of the country representatives for the college in Rwanda with my colleague, Professor Nkusi. After hearing how surgical training is carried out in the University of Rwanda, I am happy to tell you how the college does it, and I'll be happy to also to report what we have achieved currently through the COSEXA in this country. So the COSEXA is, as you all know, it's training in the Eastern, Central, and Southern Africa region. It is doing the training, conducting that training at 130 COSEXA accredited training hospitals across 19 countries. And so far, the COSEXA has more than 400 COSEXA accredited trainers and 58 master trainers. These are the people who are helping to train surgeons in the region. The College of Surgeons, as you know, is a non-profit making professional body that fosters postgraduate education in surgery and provides surgical training throughout that region, this region I have mentioned. The college delivers a common surgical training program with a common examination, and it delivers an internationally recognized surgical qualification in its two programs, the membership program and the fellowship program. So the college actually offers different fellowship programs in orthopedics, pediatric orthopedics, ENT surgery, the urology, pediatric surgery, neurosurgery, and cardiothoracic surgery, plastic surgery, and general surgery. The college has created a training pathways, and it's utilizing the resources that we usually don't utilize properly. These are the hospitals and surgeons. So when you have hospitals with surgeons, there is no way you cannot train more surgeons. So in addition to advancing education and training, the College of Surgeons is also involved in advancing standards of practice and research in surgical care. So the college currently operates in Burundi, Ethiopia, Kenya, Malawi, Mozambique, Namibia, South Sudan, Rwanda, Tanzania, Uganda, Zambia, Zimbabwe, and Sudan, and Botswana. So a COSEXA trained surgeon is expected to develop a basic understanding of anatomy, physiology, biochemistry, pharmacology, pathology, oncology, radiology, microbiology, and also he's expected to practice surgery as a consultant without supervision. So the college graduates a consultant surgeons. These are competences that are expected from the COSEXA trainees: patient care, medical knowledge, practice-based learning and improvement, interpersonal and communication skills, professionalism, and system-based practice. The methods that college uses in the residence program includes progressive apprenticeship, the didactic lectures, tutorials, seminars, management and case presentations, clinical conferences, surgical audit and mortality and morbidity meetings, radiological sessions, surgical skills lab, outpatient surgical clinics, surgical ground rounds, and teaching in the operating theater. Also journal clubs that are held bi-weekly or monthly, but also attending external conferences like the COSEXA conferences that will soon be taking place in Namibia. But also the college offers an online curriculum through a school for surgeons. This is a training resources for all the COSEXA candidates. I mean for the membership program and the fellowship program. In the membership of the college, on the School for Surgeon, you can find the foundation surgical skills, their case studies, surgery in Africa journal clubs cases, and for the fellowship program, their case studies. Candidates are required to log all operations for the duration of their training period in an electronic logbook. At the examinations, details from each logbook will be provided to the examiners, and only operative experience logged in the electronic logbook will be taken into account. And candidates will not be allowed to sit for the examination if operative experience is not adequately recorded. So going to be taking you through the requirements for the membership training. Academic requirements to be admitted to the MCS program: you have to have a degree as a Doctor of Medicine from a recognized university. You have to be a registered practitioner by the Ministry of Health. You see here in Rwanda, you have to be licensed by the Rwanda Medical and Dental Council as a medical doctor. There also are other non-academic requirements. You have to be physically and mentally healthy and not older than 40 years of age. Female candidates are strongly encouraged, and when a female doctor, they are being given special consideration to join the college. Of course, you have to be fluent in English because all the curriculum is taught in English, and examination also, they are done in English. The current situation, in Rwanda, we are having 22 trainees who are registered in the MCS program. 2 days ago, 7 of them have presented themselves to the membership clinical examination that was held on November 17. That means 2 days ago. It was an online examination, which over the years things have changed. The candidates used to go to a center and sit for clinical examination. But this time, owing also to COVID-19, things have changed. The college found it easier to organize an online clinical examination, which the candidates can sit where they are in their respective countries. So these also, I want also to go through the requirement to be admitted for the fellowship training. You have to have completed successfully the membership training, which has 2 exams, part 1 and part 2 exam. When you are in the FCS program, depending on the specialty you have chosen, you have to complete 3 years. That means 36 months, or 4 years, 48 months of training, with 1 month leave each year. You have also to submit a well-kept countersigned e-logbook with a minimum of 500 cases, a progressive assessment report from the 4 or 5 years of training, a completion of a minimum of 6 case studies out of a total of 10 case studies at School for Surgeons. And you have, of course, to pass the examination for fellowship. There are also mandatory courses. These include a research methodology course and the non-technical skills for surgeons, or another similar leadership course. Depending on the specialty, you have to, there are optional courses, like for general surgery fellowship, there is an optional courses in laparoscopy and endoscopy courses. These are optional courses, but if you can have them, it's very good. So to sit for the final qualification examination at a fellowship level, the resident must have been involved in a minimum of 500 major operative procedures, including at least 100 operative procedures in the final year of residency. So these are, currently we are having 19 trainees who are registered in different fellowship programs. In orthopedics, we have 7, general surgery 4 candidates, plastic 4, urology 3, neurosurgery 1, pediatric surgery 2, and none in cardiothoracic surgery. In Rwanda, we count so far 34 surgeons who are fellows of the college by exam, and 17 fellows who did not sit the exam, but also we have 1 member specialist. Also wanted to discuss briefly the assessment strategies at the COSEXA. So maybe I want to leave this out. It can be found on the college website. So to encourage trainees to join the COSEXA, the college has availed awards and prizes to encourage and to motivate more candidates. There is a prize, the Lindsay Stewart Prize, which is available to candidates who wish to present a scientific paper at the COSEXA scientific conference. If there is a candidate who wants to present a scientific paper, he can also be awarded the Lindsay Stewart Prize. There are also awards, scholarship, and grants available to COSEXA candidates. The Professor Gerald C. O'Sullivan Award. This is a 5-year assessment of performance of all examinations, which includes the MCS and FCS results. The Bate Scholarship This is also only available for candidates in Malawi, Zambia, and Zimbabwe. The RCSI COSEXA collaboration program and 2019 research grants. These are COSEXA awards, grants to trainees to conduct research studies that measure the impact of COSEXA on healthcare in the region. Also the UK Medical Training Initiative is a candidate can travel to the UK and stay for a maximum of 24 months, and he can benefit training and development in the UK NHS services before returning home. American College of Surgeons COSEXA Women's Scholarship. This is a scholarship that is available for women in surgical residency. There is also a Smile Train Scholarship that is available for selected COSEXA trainees who wish to study plastic surgery in Africa. There is also a travel fellowship that is available to COSEXA fellow, the COSEXA fellows, the Rahima Dawood Traveling Fellowship. Thank you very much. If maybe you'll be able to add more during the discussion, that's what I have prepared about the surgical training through the COSEXA region. Thank you very much.
Thank you very much, Dr. George. I think we initially, as they said, there's a lot of echo. This was not supposed to be really a panel discussion, but what we can do to save time, unless we have burning questions, the next on program is going to be we're supposed to take a picture, and then Prof. Abebe hasn't presented, sorry. I think time is chasing us very badly. Sorry, Prof. Abebe, please.
Thank you very much, Dr. Nkusi. Colleagues, thank you for the invitation. I'll have a very brief talk about the linkages between undergraduate education and the profession of surgery. The title of my talk is Preparing Tomorrow's Surgeons Today. So a bit of a background. I don't think most of us need such a background, but in Africa and in Rwanda, we don't have enough surgeons. I think that suffices. The surgeon density is about 0.53. What we need is about 20 per 100,000. Hence, general practitioners all over Africa has a significant role to play, including Rwanda. Particularly in district hospitals, GPs can play a role in basic surgical skills. That is chest tube insertions, abscess drainages, treatment of emergencies, appropriate diagnosis and appropriate referral, cesarean sections, wound care, and fracture manipulations. This has been established already. So it makes sense to train our GPs better from the very beginning. They are supposed to take care of it after graduation. We can't hold them accountable for mistakes done, for care not properly delivered when they are not yet prepared properly as an undergrad. If we agree on this principle, then it only makes sense to train them better. Now, how does the world address the shortage of surgeons globally? Number one, train surgeons. That is the most logical and the right thing to do. The world does not train other people to be airplane pilots. If you don't have airplane pilots, you can't fly an airplane. You cannot train somebody else to do that. Why is surgery different? If you don't have surgeons, surgery doesn't happen. Second option is train or empower general practitioners. These are bridges between students and qualified surgeons. So if we empower GPs properly, then they can fill bridges. The third is train non-surgeons. That is what we call task shifting. Many African countries do that. I leave it to you to develop your own opinion about it. I have my own, but I kind of believe that if you don't have surgeons now, train surgeons. That's the solution, not the other way around. And are there any other options? Something to explore. So the next slide shows you the linkage between undergrad education and surgery. So GPs can play a significant role. But if only there is, number one, good role modeling. If we, the surgeons, the leadership, the mentors, serve as good role models, teach them well. If there is early and standardized exposure to the surgical practice and the field of global surgery, if we help them do some procedures as students, if they touch the blade, the scissor, if they attend procedures, if they create interest from the early formation years, they might think of a career in surgery. And train them well in a standardized, well-controlled, well-regulated training program, and demystifying it. What do I mean by that? Surgery is not that complex. Let's stop painting such a picture. It has been in this world for more than 150 years. It will continue for many, many years to come. It's not rocket science. What it needs is properly trained human being. Anyone with the brain, the heart, and the hand to practice surgery should be given the opportunity to do so. So let's demystify it, consider it as a profession, as a training, and take students through the proper training process. And policymakers should also recognize the role of interns, general practitioners, and surgeons in the provision of surgery and anesthesia care. Policies should not stand on the way. They should be supportive of it. So if we consider undergrad to be the starting point for surgical practice, then we need to rethink the way we teach. Most curricula in the developing world are copy-paste of what's available in the high-income countries. But these curricula do not serve us well. They serve a certain function, but not always. There are some clear differences between developing countries and the developed world. Next slide tries to discuss that. The next slide shows that. Number one, our intake to medical school is different. We take 17 and 18 years old boys and girls who are right out of high school. In North America, those who enter medicine are those with first degrees. It's a huge difference that should be considered when we consider curricula. Second, what are the competencies expected or the graduate profiles the country and the continent needs? We want GPs who can do cesarean sections. We want GPs who can assist in appendectomies. We want GPs who can diagnose, treat, and then refer. In the developed world, that's not the case. Internship is a bridge between undergrad and residency. There is the value of the general practitioner is reducing in the developed world. For many, many years, I give it 25 years, GPs will have a significant role to play in Africa's healthcare. That's a big difference. The third is the GP's role in healthcare in a given country. Africa has a unique need and available resources. Training is tailored to what's available in country. The training should serve us. If a surgeon graduates and goes back to a district hospital where laparoscopy is not available, then training should not be stopped just because residents are not exposed to laparoscopic surgery. The training should reflect the actual situation on the ground after graduation. And finally, there are several determinants of care and treatment in Africa, what we call the social determinants. Now, at UGHE, what we try to do is we tried to design an overall medical curriculum that is very strong in surgical emergencies. 90% of what general practitioners do in Africa are emergencies. In internal medicine, they deal with infections, sepsis, malaria, NTDs. In pediatrics, they deal with diarrheal diseases, infections, trauma. OBGYN is all about abortions, bleeding, delivery and its complications, and surgery is obvious. So 90% of what GPs do is mainly around emergency. It's only logical. If we stay honest to ourselves, we should really, really focus on emergencies as undergrad students. And then what are these surgical emergencies that our GPs are mostly involved in? Mostly abdominal procedures, cesarean section, wound management, and then appropriate diagnosis, stabilization, and appropriate referral on time. So since the past 3 years, we've been involved with what we call a global curriculum development process with 3 main objectives: to outline the contents in surgery our GPs in Africa should be involved in, to design the curricula and design ways of implementing it, mainly in Rwanda and then in Africa. The next slide shows you the procedure we went through. We identified close to 100 experts mainly from Rwanda and in the region. We went through a modified Delphi process. We convened meetings online and face-to-face, identified more than 120 different content, different procedures, and finally we called for a face-to-face meeting. The next slide. These are the process we went through. In the afternoon, some of my colleagues will be talking about this in detail. And then next slide. Finally, we convened 40 experts, surgeons, general practitioners, medical students, the leadership, the RMDC, the HEC, most stakeholders, and we agreed on what are the surgical topics that African, Rwandan undergrad students should be focusing on. We tried to create an inclusive type of curriculum that serves us. The next slide shows you, these are going to be my 2 last slides. How do we link undergraduate and postgraduate education? The first one is inspire. Young people respond a lot to inspiration. If we help them, support them, guide them, I'm pretty sure many students will want to follow us. This also includes mentorship. The third is immersive pedagogy. Surgery cannot be taught in a classroom or in the library. It should be in the theater or in the emergency room. As Dr. Ntenganya said earlier, no surgical procedure should be spent or wasted. Students should be around us, if not given opportunity to participate, to assist, suture, make an incision, and be inspired in the process. We need to challenge the status quo. Copy-paste from what's existing in the world should stop. It is about time now. We cannot think about copying a curriculum from Europe or the US and start implementing here. And then maximize the bridges. Particularly, internship is a golden opportunity. Internship does not mean a junior GP. Internship does not mean a young doctor. It means final year medical school. We need to accept that. Internship is a golden opportunity for us to teach our students, to mentor our students, to support our students. This is a major paradigm shift I would encourage all of us to think about. And then next slide, the final would be to mystify the complexities. Cardiothoracic surgery, it's not rocket science. If surgeon A can do it, why not student B? If I can do it, why not the others? Neurosurgery is not a rocket science. Students should understand it can be done. It can be done. And GPs should be empowered legislatively by the ministry, by all supporting policies and structures to practice as to their best abilities. There should be policy guidelines and policy support, and practitioners should be acknowledged. Students, GPs, surgeons should be acknowledged for whatever contributing to the healthcare system. I thank you very much.
Thank you very much, Prof. Abebe. You see, the rushing for time, what was going to miss. So, having listened to all the presenters, now we should it's time for discussion. If there are people with questions, they can go back up to the podium, and then majority of them are bio and the panel discussion that's going to follow. So if you forget something now, remember it's going to come the next session. So those with questions, please. But starting from the Prof. Abebe, there is an issue on task shifting. And of course, important thing that I picked is train surgeons well. So those two things are contradictory.
Yes. Thank you, Dr. Nkusi. Task sharing, not shifting, is, I think, it's my opinion. There is also evidence to support that. Task sharing is, I think, what Africa and Rwanda needs at the moment. This means training health professionals who are in a certain career path to share some responsibility from, let's say, the surgeon, under supervision to do a certain dictated task. It is not task shifting. Task shifting is completely relegating a certain procedure to a less qualified professional. 23 African countries from 45 are strong believers of task shifting. I don't think Rwanda is one.
I don't agree with it, absolutely.
Yeah, 23 countries, unfortunately, believe in task shifting. Down the line, it leads to serious issues. There are many countries in Africa that are really struggling with decisions that were taken 15 years ago. These decisions are now backfiring. Thank you.
In that line, of course, you mentioned something to avoid copy-pasting programs. A lot of things, we break our brains, not our backs, because the thinking is the brain. Trying to imitate, and that slows down. I remember when we went for training, people used to wonder, these guys who are going to train in South Africa, they're going to come back and do nothing because there are no resources. I'm yet to see any person who trained from out and came back and is not able to practice. The issue was, if I'm trained and I need, because I've heard of an MRI in theater, and I think that is the way to go, and I want to start there. So that's the copy-pasting that he's talking about, that we should avoid at all costs. I think the rest have given us a good run through, and I don't have a question myself. But I think the Dean has a question.
Thank you very much. I don't think I'm going to ask it as a question, but maybe it's a comment to all of us, because it's as a challenge. I see it as a challenge, especially with the environment in which we teach today. We have a curriculum that says what are the competencies we should expect from medical graduate. I'm talking about an undergraduate. But the way we function and the way we operate today does really not it's not in favor of such a training. We see the neurosurgeons working in their side, they are in silo, general surgeons working in another area, and I think really it's a thought, I may be wrong, but the students get a fragmented kind of training where they are looking not at surgery as a broad competence as we could give them a package, but maybe that they get it as just neurosurgery, you need to do this, urology, you do this. We do not have that time to expose students in all of these disciplines that we have. I'm wondering, are there some strategies we could use to make sure that students get a consolidated knowledge, competencies around surgery that is not necessarily plastic, cardiothoracic, neurosurgery, but that they get a broad competence that is going to help them thrive where they are sent to practice. So it's just an issue that I see rising as we specialize further. How do we remain together? How do we work together to ensure more competence? Thank you.
Somebody wants to contribute, Prof. Foster?
Thank you, Prof. I'm just, the Dean is mentioning that, and I'm going to follow him in the same line. Actually, this is a big issue, and I think that's the touch caring that Professor Abebe was mentioning earlier should be looked at when we train. So we tend even to remove the few years that we share. So as if the surgical specialties have nothing in common. And actually we share a lot. There are a lot that, especially those basic and emergencies, that we should be teaching together. So that the young ones at least be exposed to that at a core thing. But we go further. So as we have been discussing that the Dean knows, even when we assess students, as a GP going to get out, we think that a few surgery plus small pediatrics plus small internal medicine plus small whatever make a GP. But I think a GP is a whole. And when we give exams for exit, we never give a comprehensive kind of exam. We even ask them to come to sit for surgery today, then tomorrow for pediatrics, then after tomorrow for internal medicine. We never put everything together. So that is the question that I'm sending back to the Dean. How can we do it? And how do we teach as we practice? We should actually teaching as we practice or practice as we teach. So, but we don't know where we are. Because we specialize a lot in surgery, because surgery is quite very advanced compared to others. But we really have to think about that.
I like the discussion. This discussion, I don't know whether we're starting it now or we're going to continue, but task sharing and comprehensive, I think we can even add that we have made it worse by modules now. So the segmentation is going even deeper. You examine a module and that's finished. That's even getting worse. Oh, okay. There's somebody and then you.
Hello. Yeah, my question goes to Prof. Faustin. Yeah, it's our question more about the postgraduate training in general surgery. I'm a general surgeon working at Kibogora. But you find that some patients come, orthopedic patients with open fractures, and they are coming from a hospital that has got a general surgeon, but that patient has not been debrided, and that patient has no an external fixator. And when you ask, they ask that they don't have orthopedic rotation. So I wonder how much exposure, and if we would increase our orthopedic rotation. There are some things that maybe we can share a lot during the early years of training, so that we can have a surgeon who can go in a rural setting and can manage the best for the better of the patient. Thank you.
Thank you, Ronald. So I may stand up to answer that question. And thank you for asking it, actually. So this is an issue that I call, people are forgetting what is general surgery. And we should getting back to the basis and define well. General surgery is not what is left when every specialty has taken a piece. General surgery is a comprehensive standalone specialty. So you cannot be shy to do a fracture if you know how to do it because you are a general surgeon, because there is an orthopedic colleague. No. So, and then I'm going to open this debate and to hear from different programs. So from neurosurgery to plastic surgery. So everyone is taking something. And then I was called recently from a general surgery colleague saying we have someone with an injured femoral artery. Can you please come in? This is plastic surgery. I say, what? So what are you going to be left with if there is a maxillofacial program coming in next, no one is going to be doing maxillosurgery if you are not a maxillosurgeon. Plastic surgery is there. No one is even a skin graft. You are sending them to me. This is ridiculous. So that is actually the debate. That as a society, we have to define who is doing what, yes. But specialties are not like these walls, where you have one on the left, another one on the right. We share a lot. That is the task sharing people are discussing now. And I think if we lose general surgery, we lose everyone. So for me, general surgery is the mother and the core of our specialties. So we have to come back to the basis. If you feel they are not well exposed, so please give that to the program as a feedback so that they expose them well to orthopedics, to neurosurgery, to whatever. Because I don't see why nose general surgery is now doing a bahor. So what is happening, Prof. Husi? Did you tell them don't drain an acute extradural hematoma because you are a general surgeon?
Actually, we teach them to do those emergencies. And I think, well, we can start with you. The fortunate part is that the age allows me, because most people who have gone through us, they know that we have. I see Robert, I see Christian, who used to do those surgeries with me, so they can tell us what happened. Is it because maybe equipment? I don't know. But you can tell me why they're not doing that. This discussion is not going to finish.
Thank you, Dr. Nkusi. I really like this discussion, mainly because it's very constructive. It puts things in order. In my opinion, it goes back to two main principles. Number one, let us not copy-paste from somewhere. We have, I think, 55 district hospitals in Rwanda. I may be mistaken in the numbers. We cannot place 55 plastic surgeons in each district. This all goes back to the national plan. How many plastic surgeons are, when are we going to get 55 plastic surgeons to be placed in these places? Let's say 2035. I'm just throwing out the dates here. Until that day, general surgeons are supposed to carry this responsibility. We can't hide from it. When are we going to have 55 neurosurgeons in these places? Let's say 2040. Until 2040, it's our responsibility. This translates back to the curriculum. So until 2040, the general surgeon of Rwanda is going to be unique. The general surgery of the US and Africa cannot be the same. This makes Africa unique. So our curriculum should clearly say, until 2040, the general surgeon should be able to do this. This also comes with punishment. If you don't do this, you are in trouble. If it's in the curriculum, if you have a degree that clearly states you can't do skin graft, referring is a crime. You can't be held accountable. Now here is the problem. Our trainings are so influenced by what's going on outside that we say, okay, I'm a general surgeon. I have many orthopedic colleagues. I'm going to refer them. That is not defendable in the court of law. It is not. Trust me, it's not. If it's in our job description, if it's in our license, we cannot refer patients. So number one, let's stop copy-pasting what's out there. Number two, let's design our curricula properly, and then let's implement it properly. when a general surgery trainee attaches to neurosurgery, what are the competencies you want them to have? Are they listed out? Are they ticked when you sign them off for surgery or for examination, qualification? When they come to plastic surgery, have they done the 3 months of attachment? How many grafts did they do? How many flaps did they do? Do they sit for exams after these are checked? And finally, what does Rwanda need out of a general surgeon? Are those defined? I think it's up to us, the professionals, to decide that. And in it. Neurosurgeons, enough plastic surgeons, enough chest surgeons, the general surgeon is going to look like this. We might even say we don't need general surgeons from now on. But until that day comes, we should face the facts. We should face the truth. Thank you.
Thank you. Just talk about what Professor Moses talked about. Back in 2016, we had a small training about. But when I went back to my hospital, I discussed with anesthesia, and the anesthesiologist told me, I will not give anesthesia for your patient when you are going to do epidural or subdural. It is not really feasible here. So it is a whole process that has to be implemented. So if I can do this skill, but the anesthesia, the ICU is not there, it's not possible. Also, I have a little bit of alarm. We have fewer general surgery trainees. We will not have a PGY for this coming year because of COVID. And the ones in PGY 3, I think only 3. And fewer even, lesser in the earlier stages. So general surgery is kind of disappearing. If not, nothing is done. But general surgery, as you know, is the base for all surgery. Thank you.
Yes. So I think we'll get one more question and maybe an intervention by Dr. George, and then we'll follow up with the next session. Thank you.
Thank you very much. I have a couple of questions here, but before I ask my questions, I just want to quickly make a short comment on what Dr. Abebe said last. In as much as I agree with almost everything you said about how doctors should be trained, especially general surgeons, that they must be responsible until we have those specialties available in Rwanda. But I think that it would be a huge mistake to, for example, to criminalize, like you said. So for instance, if it is part of your curriculum as a general surgeon to know skin grafting, and then you require skin grafting, well, it wouldn't be nice for us to criminalize such, because remember that the very good doctor or the very good surgeon is that one that knows his limits. I must have actually gone through a particular training, but I might not be comfortable with that procedure. So the onus is on you to know where the limits of your ability. So we must still, in as much as my curriculum says I must know skin grafting, but if I know I am very poor at skin grafting, I must still have that option of being able to refer to the next center where I feel that a better colleague or a more comfortable colleague is. So that's my opinion about that, sir. My questions. My first question is that it is to, sorry I couldn't get the name, the first speaker that talked about the history of surgery in Rwanda. In as much as we understood the fact that before 1996, from 1962 to 1996, there actually was no postgraduate training in Rwanda. What was responsible? Why were we sleeping for 30 years? What was the cause? Were we just not interested in postgraduate surgical training? That, I think you should let us know why. What was responsible for that? My second question goes to Professor Faustin. Surgical training is becoming interesting in Rwanda. You have 7 major training sites. You have new ones already that are coming in. However, my concern is this. In the process of let's assume now that we have maybe 14 training sites. In the process of not letting one training site just be abandoned or not being used, how are we like monitoring what we are sending students to do? For instance, if for surgical training or your surgical posting you are sending to a particular center, are we sure that there are enough procedures to be witnessed by these students? Or are we just sending them because that institution is on the list and we must not abandon that institution? Is there a procedure to know what is in what area? If it is general surgery, you have to send to maybe Butari. If it is urology, you have to send to the military hospital. Is there a procedure like that? Or we are just like, we've got 14. They must rotate through the 14 so that those are used. My next question is for Dr. Georges on COSESA. It is obvious from that map you showed us, why is South Africa significantly left out as a country? Or are they the one holding back in joining COSESA? That's the first question for you. And the second question is that in your training, one of the requirements is that the person must be less than 40 years of age. What is responsible for that? Why are we limiting the age to 40 years 40 years old? Another question for Professor Abebe would be that if you are looking at the surgical training or medical training generally, might not be unique to Rwanda. This is a question about curriculum as well. We see that maybe for surgical posting, you have 8 to 12 weeks of maybe a junior posting, and then maybe another, maybe 8 to 10 weeks or 8 to 12 weeks of the senior posting. Do we actually think, we have to first remember that medicine, not only surgery, is not only scientific, but there's an art to medicine. So the art of medicine is that apprenticeship. Apprenticeship is about the more I see, the more I practice. But this timing that we are giving our students, do we think it is enough to provide for us that general surgeon or that general practitioner, at the end of the year that actually can cater for our needs in Africa? Thank you very much.
So, I had hoped for only one question, but it seems there are multiple questions. So we'll try to make the answers, we'll make the answers as quickly as possible. And I will let, you had a question.
Thank you. Thank you very much. I'm going to first give my comment. I'm going to build my comment from what Dr. Ronald said exactly. That critic about the resident or the surgeon who did not debride and refer the patient to him. So I was in the training of surgical residents a few years ago, and I think all this is arising from some of the mistakes that we all have done. I remember we used to have a common basic surgical training for all postgraduates, and they would join the specialty after 2 years. And they would rotate in all the specialties, in orthopedics, in neurosurgery, and they would learn everything. And of course, when they joined their specialty of choice, like if you go to urology, you would specialize in urology, but you would have what I would say, like you had skills as a basic surgical skills that you need if you are confronted with another patient who is not you. But you can manage every surgical emergency. That's what I'm saying. But now, if we have just rejected that system, and we are now also pretending that we are training our MC in the same system. COSESA is supposed to be training membership for 2 years. But now I have seen also that when you join the graduate training in surgery, you can only be exposed for just 1 year, and you join a specialty, let's say neurosurgery. You would not have completed the required. I was suggesting that maybe we could reconsider the way we are doing our surgical training. Maybe there is an example in Namibia, in this Zambia, where they have actually opted to not implement different curriculum. Some of the African countries, member of the COSEXA, have decided maybe to apply the COSEXA curriculum, which offers like a 2 years membership training, and then they can choose a specialty. What about us? If we are now having these deficiencies where our graduates are not able to manage surgical emergencies properly, I think that is a discussion that we can have at the level of Rwanda Surgical Society and maybe make some proposal to the School of Medicine. I would like also maybe for my colleague who asked why COSEXA is not considering training more than 40 years old, maybe Professor Abebe, who is in education, is maybe having an answer. For me, I don't have one. I don't see why 40 years old who want to do surgery cannot be trained. I don't agree with that.
Dr. George, you told us about should be mentally sound. You can tell us how do you assess mentally sound? A mentally sound person. Do you take them through assessment of their mental status? Because you mentioned there that they must be mentally sound. That looks like the 40-year-old.
I think for the sake of time, and I'm very happy about this discussion. Okay, so this is the last Vernick comment. Thank you.
No, thank you. Just one quick comment. I'm very happy to be part of this conversation because it feeds into what we've been discussing with the Dean for even internal medicine. You see, we have this discussion about specializing people directly from general practitioner to cardiology or to gastroenterology as it's done in some of the settings. But having this conversation here about surgery aligns me a lot in the decision that we'll be making in the future. But one thing that I would like to ask you all, as much as Professor George is saying that we have probably made some mistakes in the past, but what data supports that? What's the evidence that shows that if we reverse back to the other model, we'll be doing better? Do you have any evidence? Do you have any facts? How do we do it in a way that's systematic to inform the policy change that we want to make? That's the only challenge that I want to throw out to you.
Let me thank all of you for this great participation. It's been excellent. I know actually people have more questions than when we started, including myself. You know the reason? Now the guest of honor, since he decided to stay with us, I am very happy with you to stay, and the director of planning. So there is this, the surgeons wanting, as usual, to do a lot. How much are we protected? Don't think about it. But in the next session, you think about it. Because if I do skin grafting, and this guy is not happy with my the outcome, he sues me and then they take me to court and ask me, by the way, what is your qualification? I am a general surgeon. Let's see, are you supposed to do skin grafting? Am I not told that it's a plastic surgeon's job? So you have to go back to the curriculum and write that a general surgeon is supposed to do this. Otherwise, we have some evidence here. There is Prof. Kaibanda is here. He will tell us later on what happened when he drained epimyositis. I thank you very much for having participated in this session. It's been very lively, and the next one is going to be fire. Thank you very much. Let's move to the next one.
Thank you very much for this lively discussion. I hope there's part of the room that was silent, but I guess this is their time because we are going to now welcome the next, and this time it will be a panel discussion. We'll have two moderators that were already presented before. We'll be with the two moderators, Professor Emile Guamasirabo and Professor Nirenganya Faustin. We'll be welcoming the panelists, and we'll share with you the challenges on surgical trainings, and there will be also some perspective from the residents. So that's why I hope that we'll also get to hear from them. Thank you. So in the meantime, I would be calling maybe the panelists. So we'll be with Dr. Wariraye Parfait, please, from the Ministry of Health. And we'll be with Professor Byiringiro Jean-Claude, Dean of Faculty of Medicine at CMHS. We'll be also with Dr. Ntaganda Edmond, from CHK. We'll be with Dr. Shingiro Eric, a newly graduate from neurosurgery, and Dr. Umugwaneza Natalie from CHK. Yes.
Thank you, moderator. So the members of the panel, please, you are welcome to join the front seats. Can I have another chair? Prof, can you come, please? Good morning, everyone. Thank you for joining us on this panel. So I'm gonna let Professor Guamasirabo to start, and we'll join him on board.
Good morning once again. So, as you may have noticed, we have a number of themes to discuss about. The first one is about the national surgical anesthesia and obstetric plans. And the second one, surgical education governance. Third, program design, delivery, and evaluation. Then individual programs perspective. And finally, surgical training in Rwanda from a trainee's perspective. I'm going to start with engaging the panel members. We'll start with the head of department of planning in the Ministry of Health, Dr. Parfait Wariraye, about the NSOP, National Surgical Obstetric Anesthesia Plan. As many countries, Rwanda also developed this plan some years back. I think it's 2018, with targets for 2030. As you know, there are Lancet Commission targets for 2030, and we have made that plan, and this is the time to hear from the head of planning in the ministry to know how far we have gone. Dr. Parfait, would you please please take up, this assignment. Thank you.
Thank you very much, Professor Emil, moderator. All protocol observed. Good morning once again. Going straight to the point about the NSOP. In Rwanda, the first NSOP has been developed in 2018. It will run for 7 years. We are now implementing the NSOP. The plan is structured according to our strategic plan. It's taking care of the governance, the service delivery model, and the monitoring and evaluation, but as well the financing of the plan. So the plan has been developed through a consultative process, but the aim of this developing on this plan was not just to develop, but implement the surgical plan. As some of the previous speaker has mentioned in this conference, so we need to strengthen the surgical system, and we can't achieve universal coverage if surgical system are not strengthened. It means you strengthen all the blocks of the surgical system, from the governance, leadership governance, service delivery, supplies, the financing, as well as the data systems. That's what we put together and at the NSOP. So where are we now? In terms of measuring the progress has been, I can say the progress is measured according to the indicator that has been set by the Lancet Commission of Global Surgery. Sometimes back 2015 with 15 years target up to 2030. There's still a long way to go. When we develop the NSOP, we put a kind of midterm target to ensure that it can reflect our current need, our current capacity, but also the realistic way of setting, but not forgetting the global target that has been set by NSOP. I'll start by the first indicator. The first indicator is about the timely access to surgical services. The global target says less than 2 hours. When we did the NSOP, we started, but also when we monitor them on a yearly basis, we found that people are accessing surgical services in less than 2 hours. That means it's a very good progress. When it comes to the second indicator, increasing the surgical volume, we still have a long way to go. Increasing the surgical volume, some of the discussion we're discussing here, it's about increasing surgical volume. As of now, we are still at 100 to 1 million. So we need to increase at least the target is to have at least by 2024 to 5,000 per 1 million. So you can imagine now moving from 1,200 something surgery up to 500. But by surgery I mean the definition by what has been said by in the NSOP. It's mean any incision, excision, manipulation of tissue that require deep anesthesia. This includes most of the time in the simple terms, it's mean the major procedure. So we still have to increase those surgical volumes. So there is still some strategy that we want to put in place. Some of them has been highlighted here, increasing the volume of bellwether procedure, the capacity for the GPs. As of now, the Ministry of Health developed legal framework for credentialing, the privileging. We'll need the support as the society to help us to implement these things. So GPs, but also other I'll say, not well recognized surgeon can perform some of those procedure according to the norm and the standards. The other indicator, it's about the SRO provider is also we're still lagging behind. It's 12, as rightly mentioned by the guest of honor today. We need to reach 200 per 1,000 population. So it also requires more training, but also more people, I would say, credential and privilege to do the surgery, especially those bellwether procedures. For postoperative mortality tracking rate is quite a very good progress. We have built the data system. As of now, we can track the postoperative mortality rate. It's something that we keep monitoring, because with data, you know that it can fluctuating, but we have to keep our eye on the entity that are reporting to the Ministry of Health, but at the same time providing feedback. Other two indicators about the financing, the catastrophic expenditure and the impoverishment rate due to access to surgical. So we're supposed to be at least less than 80%. Where, I mean, protection. This is about protection. We have found that through the NSOP, when we did the NSOP and calculate this, computerize this indicator, we are quite having very good progress. I would say as of now, we are above 85% of our people are quite are protected to catastrophic expenditure, including also the also the impoverishment, following the impoverishment due to accessing surgical service. And this spirit is still ongoing as the Ministry of Health to mobilize more resources to ensure that we can empower our hospital in terms of providing whatever they need, but also advocating for more money to sustain, of course, this community-based insurance. That's what most of our people are using to ensure that they can get more protected when they are accessing services to the surgical services. So these are I would say the summary where we have been now. We still have a long way to go. We need stakeholder support, but also more engagement, advocacy, to ensure that at least what I've set as any sub target by the end of 2030, but of course, as we are heading to 2024, we can achieve it. I would like also again to inform you that we are going to conduct a midterm review of NSOP very soon to see what are the progress we have made so far. So with the support with some of the leadership, the leaders from the RSS, but also other stakeholder professional association that's involved in NSOP, we'll conduct it through the steering committee of the NSOP. So thank you very much, Prof.
Thank you, Dr. Parfait. I think more questions will come from the audience at the later stage. Let me move to the Dean of our medical school at UR, Prof. Byiringiro. As said earlier, we are decentralizing education, medical education and surgical education for that matter, to more training sites. We are moving to more training sites. Of course, this requires the education, the surgical education governance to follow. And those departments where we'll be sending trainees should be able to handle all the academic administration, the follow-up, the objective, the follow-up, the assessment, all those things. What plans do you have to ensure that education given to site A equals to education given to site B? in short, to ensure that trainees are not going to be at the disadvantage when moving to a remote site? What plans do we have for that?
Thank you very much, Professor Gwamasirabo. Good morning, everyone. I'm Jean-Claude Byiringiro. I'm the Dean of the School of Medicine and Pharmacy. And I'm happy to be here today to discuss matters regarding education and specifically surgical education. I'm very happy to discuss this question, which is among the most difficult to approach. Governance of medical education is always challenging. Why? Because of the nature of educating medical and surgical professionals. One of the challenges that is here is the ability to navigate through the systems. One being the system of education on one side, with the Ministry of Education, the university. Another challenge is navigating through the service provision, hospitals, and the Ministry of Health. And the linkage between all of these systems is not always very easy. However, recently there have been some discussions which brought some positive fruits that we probably are to explore and see and evaluate the performance of a such system. That is about integrating medical education and healthcare provision. You know that back in 2020, the government has decided to integrate more medical education with health services provision through the Ministry of Health by creating the HRH Secretariat. I think this was a very nice dynamic, which is going to establish this link that was somehow missing. And that brings together all the stakeholders. So that's a very high level decision, and that I like so much. By bringing it, I believe it will help at the higher level of the governance, because the synergy between the two systems, I believe, is going to take medical education, surgical education to another mile. Going then downwards to the level of the governance is the partnership between the school and the teaching hospitals. We have now 2 levels of teaching hospitals, and this is also another very good move. We have the major, if I can say, major teaching hospitals, and we have the second level teaching hospitals. Then the link between this institution of care provision and the medical schools is going to be very key. The collaboration between the executives of those hospitals, teaching hospitals, and the medical school, that I'm seeing taking more shape today, is of paramount importance. We are now more collaborating with the heads of institutions more than we used to do before, which is very positive to me. And it becomes much easier for me to communicate with them so that we can communicate to other levels. There are so many levels, of course, but I'm going to insist on one that is a department level. The department is our implementation unit. It's where everything takes place. In a bill to integrate more, the university and the Ministry of Health, we agreed on more coordination at the department level, and we have now established a chairmanship, the department chairmanship. So now everyone every head of the department at a teaching hospital is a member of faculty, which is good. Now, all these heads of department at teaching hospitals are coordinated by the department chair, Faustin here, who is now more collaboratively working with them. So they are required to implement the programs and to report to the department chair, who is here, and this becomes an efficient link between the office of the dean, the department, and the teaching side. It's a new system that has not yet been evaluated, and we do not know yet how it is going to behave, but I believe that this kind of coming together is going to pay more return to us. What the next change that is going to happen is the official recognition of program directors. Each program, we believe, will have an officially appointed program director to coordinate a program now under the department chair. So the program coordinator or program director, is going to be the overall leader in the implementation of a given program. As you have seen, Faustin is now counting 10 programs in the Department of Surgery, and this, each of them is going to get a program director, and the program director and the department chair will be given also program coordination, which is another level that didn't exist before, where this coordination level provide administrative support to the department chair and program directors to be able to deliver. So all of these are the changes in the governance which have just started, that we are yet to evaluate and see, but we are reforming it, and I hope that we will have more time to discuss with our colleagues in the hospitals on these changes and reforms that are directed to improving the provision of our surgical medical education in general. Thank you very much, Professor. I want to stop by here and we'll continue by the discussion.
Thank you very much, Mr. Dean. And we expect questions from the audience later. Let me hand over the microphone to Professor Faustin for the next question.
Thank you, Dean, and thank you, HOD Parfait. So in the same line, I'm going to invite Dr. Edmond, the head of education and training within Rwanda Surgical Society, to move out the University of Rwanda. Then we discuss what are we doing in Rwanda. So how do we, in that line of governance, how do we ensure that COSESA, University of Rwanda, UGH, and anyone else who is training surgically is aligned, and we produce surgeons of acceptable standards from each and everyone who is training?
Thank you, Prof. Faustin, for the opportunity to talk about the perspective of the society in education and training. I will probably also have an kind of take a bit of a turn also to speak from a perspective of a program director. So in the society, as presented in the first session, we have two main tracks for training that is implemented by the members of the society. So they are the ones that are part of the university, but also the ones that are fellows of the college with the various programs. So the research and education committee works with the committee in general, mainly to oversee the training through COSEXA, but having two hats, being also members of the faculty in the UR, they are also actively involved in that perspective. So the standards are ensured by, of course, the college itself, because we don't conduct the exams or the assessments individually, we conduct them as a college. So the Rwanda Surgical Society, being a chapter of the college, ensures that what is agreed upon within the college is transmitted down to the trainees by ensuring that the trainees are prepared and facilitated to do so. So if I look at it from a perspective of a program director, all the programs are not at the same level. They have not started at the same time, and they don't have the same abilities to function. You've seen we have 62 general surgeons, we have 27 orthopedic surgeons, 8 neurosurgeons, but some specialties like plastics with 2 local faculty members, pediatric surgery with 2 local faculty members. It's a bit of a different challenge when you're looking at training. So some of the services need to be started from scratch so that you can be able to deliver training. As Prof. Abebe said, surgery is not taught in a classroom and then you write exams. So you need to be able to have a service that is able to demonstrate what you are saying is in your curriculum. That development of service is different according to the specialty. When you started training, we've said about the accredited COSEXA training sites. Rwanda has a number of them, and different hospitals have different accredited programs. So each program has to kind of specialty pull themselves together, see, is this site appropriate for training? And then you apply, and then your site is assessed. So that's a lot of preparation that requires human resource. And then when you are introducing a new program, or if you have a program that has already a curriculum that needs to be reviewed, you need to pull together your people. And the small programs or the beginning programs, they need to rely on collegiality of colleagues from the region, colleagues from other societies, so that they help you to develop that curriculum, because the requirements from HEC do not change because the program is small or is just trying to start. The requirements are the same for general surgery, the same for neurosurgery, and the same for ENT. You have to abide by those. The issue of small faculty number hampers some of the programs to deliver. So for the beginning programs, but also for the existing ones, teaching is not innate. You need to be mentored through it, and then you grow. As the program grows, the trainers grows, and the trainees, I think we will have a perspective from the trainees, they also grow. So teaching is not innate. We have to learn how to do it and learn from the best, and that's, I think, the way that we'll be able to deliver world-class training program. Thank you.
Thank you very much. This is very good insights from the society and the program level. So let's go to Natalie. So I don't know if you all know Dr. Natalie. Dr. Natalie Mgwaneza is our young general surgeon, and probably a few of you know that she has been the best performer for all the COSEXA candidates when she sat for her exams. Congratulations, Natalie. So now, That being said, you have been here in the morning when, as a community, you have been accused that we don't attract women. So what is your say about that, and what do you advise? How can we go about?
Thank you very much, Prof, for the warm introduction. Can I address the question first? Okay. So personally, as a woman in surgery, I think I've been inspired throughout my training, and I wouldn't say that you don't attract women, and they are very encouraged. As it has been said by Prof. Abebe, we need to demystify surgery, and being a woman shouldn't be a barrier to joining surgical training and to be able to share and impact surgical care and improve health care in our country. So everyone is welcome, and I'm very grateful for having been given the opportunity to train, and let me progress to share my experience. As Prof. Nirenganya has said, I'm a recent graduate from the University of Rwanda General Surgery Training. I'm also a trainee in the COSEXA General Surgery program. I will sit for the examination this December. So as someone who has been through this journey so recently, I'm having the greatest privilege to share my experience and hopefully be a voice for the other trainees who are still on this road. So first of all, many trainees in surgery are through the various programs which have been already presented. So they are increasing daily, and we are so immensely grateful for the government of Rwanda, for the Ministry of Health, for the Ministry of Education, and Rwanda Surgical Society for having pioneered surgical training in the country and having been able to access surgical training locally. So on the behalf of everyone, we are very grateful for this immense opportunity. So trainees are enrolled in UR programs, but also in COSEXA programs, but also there are those who do both programs concomitantly. So there are residents, but there are also fellows who are enrolled in programs post finishing their initial general surgery training, and then they join fellowship, especially in plastic and pediatric surgery. So we rotate in various hospitals, mainly the urban large teaching hospitals that has been mentioned before, including CHUK, King Faisal Hospital, RMH, CHUB, but we also get opportunities to rotate in district rural hospitals and get exposure to the diverse range of patients. So most of our time is spent during clinical exposure, during clinical work, taking care of patients, both the preoperative management, the intraoperative management, and post-op, and then along the journey, picking up the skills that are needed to become a surgeon. But apart from the clinical exposure, we also attend lectures, we also attend workshops, we are also involved in research activities. Sometimes there are ongoing research from our mentors or in the surgical departments we are at, but we also are required to do original research as a requirement to finish postgrad training. So it is a huge part of our training and the journey. So I've already mentioned the opportunities that we get, but some of the opportunities were also mentioned in the prior discussions. And I can add that apart from the rotations in the hospitals, the lectures, research activities, we are also have the privilege to get external rotations. Due to the COVID pandemic, this has been halted, but prior to that, there used to be external rotations, and personally, as someone who got that opportunity, would like to express my gratitude to the department for having that in place. I had an opportunity to rotate for 1 month in the United States and to observe and see perspective from another angle, from high income settings, and to compare those both perspectives, and it was hugely eye-opening and enriching. So let me take some time to talk about some of the challenges as a recent graduate from training. I will talk about a challenge about research. Yes, we are involved in research, but there's still limited training and activities in research, and most of the trainees will also say the same thing. It's not easy to carry out the research. The funding needed to conduct proper research is still limited, so that is one of the challenge. I will also talk about the challenge in mentorship. Yes, we are so grateful for the dedicated surgeons, despite being very few and having a high workload. They also are very dedicated to training and teaching, and that's how we have been able to be trained. But there's still a gap in mentoring, especially from undergraduate all the way through postgraduate, and sitting with trainees to discuss future goals, career path, and something I can comment on. It's not easy to even choose like a subspecialty for something you have never been exposed to. So there is still a need to mentor trainees so that their goals can be well set, and then their future careers can be set from an early stage. So there is also an inequality in clinical experience because hospitals don't have same resources, and sometimes if you rotate in one area, you're not the same skills and exposure as someone who rotated in another hospital. That's also another challenge. There is also a challenge in simulation training. We sometimes get workshops, but it's something that can be increased. Recently, the department has been pioneering dissection courses for anatomy, and that can probably be extended to surgical skills education, so that skills knowledge can be boosted before going into clinical practice on real patients. So there is what I've mentioned, that external rotations and exchange program are still limited and really helpful. For instance, if there are some subspecialty which are not yet available in the country, and we would like to inspire surgeons to join those specialties, it would be needed if they could have that hands-on experience to rotate in that specialty and to be inspired to join it. It's not going to be easy if they have never heard of it or have never seen it. So there is also the burnout. The residents are very few. The workload is also high due to the scarce surgeon and surgical trainees, and this can impact on performance. It can also impact on patient care. So there is also insufficient dedicated time for personal reading and learning due to the high workload in relation to the high working hours. So as proposed solutions, some of them I've already mentioned. So we can improve on research activities, on structured mentorship for trainees, on setting standards for training sites so that they can meet learning objectives and needs for trainees, increase on surgical simulation training, increase on external rotation for exposure to specialties that are not yet available, so that residents and fellows can be inspired to join subspecialties and work-life balance for trainees, to define the working hours and to define the learning, dedicated time for reading and learning, so that clinical skills can go along with good medical knowledge. Thank you very much.
Thank you, Dr. Natari, for this wonderful expose. You really did it well, and that's why it is always good to have women around, and the best among us probably are women. So let's move to Eric. Eric, Dr. Shinjiro he finished his neurosurgery training last week. So, Eric, hearing what the head of planning from the ministry put on the NSOP and the other plans that are around to monitor it, implement it fully, hearing what the dean said about governance and integrating medical and surgical education into hospitals, hearing what the society is talking about, how do we leverage every force around to train better. So as a new graduate, someone who is going to jump tomorrow into the practice, do you feel the system is ready for you?
Thank you, Prof. Thank you, everyone, for this big opportunity to talk to you. Maybe, as they said, I'm Eric Shinjiro, who is shifting from 6-year residence in neurosurgery to consultants as a neurosurgery soon. So I'm really glad to talk to in this platform. Surgical training, it's like you can imagine a father who is holding a child and is showing the way. So a father being a mentor and a trainee being a child. So to get to the destination, both of them have to have a commitment and everyone playing his role in his job. So to get to that destination, a mentor have to show you a way, and the child to get to destination, you have to have that mind, to be a will to get to the destination. So both of them have to be ready to get to the final destination. So maybe the message to students, medical students and fellow residents, why to choose surgery? When I started residence in my first year, most of questions they were asking me as in the surgery, you guys, are you going to do this where people, we have many trauma patients, you have many patients in ICU, they say, are you going to bear that bad outcome? But when I realized and I compare, maybe medical people from internal medicine don't throw me stones, I can say that surgery has better outcome than internal medicine, than everything. So we really do have better outcome. So don't be shy as saying the outcome is bad. So surgery is life-saving. It's not bad outcome at all. As far as I have been in that journey, and it's reviving, it's life-saving. So please, surgery is better than any medical field you can have. And then, as prior presenter said, mainly Professor Bebe, we still have a high demand. The demand is there. So surgery is still need force. The mentorship. if I speak on my perspective, I have never been frustrated as not having mentorship. My mentor was always behind me, and have every day in OPD, in the theater, you really feel confident and comfortable. So I'm really think the mentorship, yes, but we really have a mentorship in our surgical training, in our program. So you will not be overwhelmed. Overall, do you think surgeons have a good remuneration? Don't think they are poor. So don't think, I think that's also something to, sometimes we forget that surgeons are really good in terms of getting their take home. So again, for medical students and residents, keep the track. The future is good. But despite long journey, so you will meet some challenges. Most of the time, the social life is in jeopardy. So you have to keep that in mind. But because if your focus and the goodwill, will be able to do that. And sometimes some challenges, hospital work, overtake academic work if you are not focusing that. And again, the challenge when you are in area, in our training, we are not exposed early in research, and then you end up you should have a research which have been exposed early during your career, and then some of us, some get difficult to end that exercise. So exposing residents and students early in research activity, I think is of big paramount. The challenge, some hospital who helps really residents for welfare and teaching by providing allowances. So, but there is others who still lagging behind. That's why I'm amending them to really consider the work residents. They are students, but they really do help. So the allowance to the residents, night duties, where to good night duties. There's some hospital who really you found, surgery has really increased. It's no longer general surgery. There is neurosurgery or neurology. So to find all those people in one single room, overcrowded, that's really, and they have been passed more than 42 hours. So increase on that aspect will also increase the welfare of re-education and teaching. And mentorship. So surgery during the training, some who report come hardship from mentors. Hardship, harassment. So it's a call for surgeons. We now in the new century, sometime you need to sit with your trainee and share some cup of coffee. I really commend and I really clap for my mentor. I always had coffee every time I want. I really thank Prof. Musi. I always have coffee. I have never missed a cup of coffee. So that's why I think maybe medical student, please join neurosurgery. You will never miss a cup of coffee in our unit. So to end this long journey, you have to have a mental stability and a psychological stability. So despite that hardship, keep on track, and the focus, we do it. as I did it. 6 years, there is of course ups and downs, but we do it. To end my presentation or my talk, so I would like some thought on research, because to get data collection most of the time difficult, and we end up doing outcome research because of getting data. So that's why I'm thinking if we from Ministry of Health, if we digitalize some registries, some registries, for example, brain tumor registries, trauma registries, so that will help to do multi-center studies, so we increase our research input. Some has been said by my colleague, Dr. Natari, who really presented well about external rotation facilitation. It helps, yes, to see on other side of how things are done. And financial support to research of dissertation of residents. If you want us to give a tangible and society constructing result, we have to invest in this research for dissertation of residents. So I really acknowledge the mentorship we get from University of Rwanda. Especially I congratulate Prof. Shegu, Prof. Oste. They have really created a now it's game changer in this surgical training. Those cadaver courses really are really good. I wish I was being exposed earlier on, because they come when I was already ending my training. Maybe I have been more. I am better, but I will be more better than than maybe before. So thank you so much for this opportunity.
Thank you, Dr. Shingiro. That was good. And with that, we are going to wrap up the panel, because we are running out of time. So we thank all the panelists from the Dean, the HOD Planning, the Rwanda Surgical Society, and our fellow graduates. So we taking note of what has been exposed. So the discussions may continue around a cup of coffee, and I'm inviting all the program directors to see Prof. Nkusi, so that they understand how things are done. And then later on, I will ask Prof. Rwamasirabo to have a closing word of this panel. Thank you.
Thank you. There's really not much to add. I think the panel members have given us the status of the topics that were going to be discussed. I think if we don't have the time for taking questions from the floor, we can just call it a day.
Thank you very much. The panel is closed.
Thank you. Thank you so much for, I thank a lot the moderators, as well as the panelists. And as you've seen, we are now going to head for the next panel. But I would like to request, if possible, that we get a small picture together with the guest of honor right in front, and then we'll start the next session. Could we get a picture, please, with the whole group? So the panelists could stay. We'll take a small picture. Thank you. Yes. I think the wagafotozi watufashe on how to set up. We some can even the tallest can also go behind. There's some place, yes, for everybody. Yes. So well, how do you yes, you continue above. Yeah. Above. Good. Yeah. Remember that surgeons also smile sometimes, as much as possible. Thank you. Thank you very much. Yes. So I will now quickly call the next session, which will be mostly about presentation. We have two moderators for the next one. They've been presented even before. Please get back to your seats, have a seat, so that we can start the next session. The next panel will be moderated by two great mentors and doctors who already have been presented before. We'll be with Dr. Ntaganda Edmond and from CHK, leading the pediatric surgery program, and Dr. Mirimbanyi Christophe from Kibagabaga Hospital. And this time we'll be now discussing about evidence-based surgical practice. Please help me welcome the two moderators. No one is clapping anymore. We are still looking for graduates. Okay.
Thank you, Miguel. I think we are a bit behind. That's why maybe the clapping is also lagging. So please come. So without any undue delays, we'll call upon Prof. Faustin Hirenganya to start up this session, which will be discussing evidence-based surgical practice. So we've heard from Natalie, we've heard from other interveners that research has to be a big component of what we do, and then what comes out of this research is going to inform our practice, but also will help us answer the questions that we have arising from our practice. So the first presentation is a randomized clinical trial that is talking about instrument change at the time of wound closure to reduce surgical site infection in low and middle income countries. This trial is named CHEETAH. Prof. Nirenganya, welcome to the stage.
I think it's a good afternoon. Good afternoon, everyone. Thank you, moderator, for inviting me to share CHEETAH. CHEETAH is a cluster randomized trial of sterile glove and instrument change before wound closure, aiming to reduce surgical site infection. So this is an international study, and I'm happy to recognize the contribution of all the co-authors who contribute to this huge and game changer kind of clinical trial. Next, please. We are the Global Surgery Research Hub. This is a consortium of researchers across the world, and we as Rwanda, the University of Rwanda and other colleagues are part of that network. And we meet every year to agree on the priorities in terms of research. And in the last 3 years, our focus was around surgical infections. And CHEETAH and the other clinical trials that we will be seeing today coming from this Delphi prioritization that we conducted here in Rwanda back in 2018. So that is the last one which happened here. So surgical site infection remains the most common complication in surgery around the world. WHO is not recommending changing glove and instrument prior to wound closure after abdominal surgery, just simply because there is no evidence supporting that. So this study aimed to test whether a routine change of gloves and instrument prior to wound closure after abdominal surgery may reduce abdominal surgical infections. And we also assessed its cost implications. As I said, this was a cluster randomized trial, and the cluster was actually a hospital, and we didn't randomize the patients. Actually, we randomized hospitals. So each country was requested to at least to have 4 hospitals included in the clinical trial, and the sites were pre-selected, and sometimes some specific theaters were selected for the purpose of this study. We accounted for biases and predicted imbalances like urgency, incision, and contamination. The inclusion criteria, we included both adults and children, and for the incision, we only accepted incisions longer than 5 centimeters, and we included from clinically contaminated to dirty wounds. However, C-section were not included. As you will understand, if we include C-sections, the result will be reflecting C-sections because it is the main procedure done, and we excluded it for that purpose, even if it is a clinically contaminated wound. So the intervention was to change gloves and closing instruments before closing abdominal wound after abdominal surgery. Then we are comparing that to the routine practice, whatever routine practice you are doing. And the outcome measure the primary outcome was surgical site infection at 30 days postoperatively, and this was defined using CDC criteria. At the end, 81 hospitals have been randomized from 7 countries and putting it together around 13,000 patients. So in the intervention arm, so 39 hospitals were included, and in the control arm, they were 42. One hospital has been dropped from the control arm because they just pulled out, and the analysis was only accounting for 41 hospitals in the routine practice versus 39 in the intervention. The main results, as you see this, next slide please. Try to follow what I say. The main results, you see this, the graph here, you show the anticipated and actually the actual recruitment rates. So in the gray, you have what we were anticipating as patients, and the red or orange is what we got. So we have been above the anticipated recruitment rate, which is really showing the good uptake of the trial among the participants, the participating hospitals. Next, please. In the numbers of patients enrolled per country, so I will highlight Rwanda because we are in Rwanda, but as you see, the other countries participated as well. But Rwanda-wise, we put in this trial around 3,000 patients, which is a very good number, representing almost 1/4 of the patients. Considering the per capita analysis, Rwanda actually contributed the most. If you compare the population of Rwanda, the population of India, so if you put in 3,000, it's a huge contribution. So next, please. We have young people, as you know, around 40 years of age, male and women equally represented, and there was no comorbidities significantly in both groups. Next, please. If you look into the other demographic characteristics of our patient we had, so you will see that there was a tendency to have more ASTA3 patients in the control arm, and much more of cancers in the intervention. But both of these were not significant. So the intervention arm had 50% of the electives versus 42 in the control arm. Next, please. And the main incision was midline. Next slide. Midline incisions, and 30 wounds were representing 19% in the control arm. The majority of patients have been followed using phone, and this is another study that you will be seeing later, which embedded in this trial, a SWAT, the main study within a trial. So, which was assessing actually the sensitivity of the phone call to follow up post-operative patients. The main result is this one. As you see, the surgical site infection rate was quite statistically reduced when we compare the control and the intervention arm with in the reference group, which is the control group, we were having around 19% of surgical site infections versus 16% in the control group, in the intervention arm, with a very significant p-value that you see there. So after adjustment of all the sensitivity analysis, so we saw that this trend is consistent through all the sensitivity analysis done. And this is quite very interesting. Next, please. In the secondary outcomes which we analyzed, so it means mortality, surgical site infection at discharge, readmissions, reoperations, return to normal activities, there was no difference. Next, please. So this slide is maybe the most important slide. So this was a Cheetah health economic evaluation. So it is showing that all the points are in the northeast and the southeast quadrant. So those who are used to be interpreting those kind of graphs, this means that these Cheetah interventions are cost effective. So this is a very important probably message to give to the policymakers and those who are managing hospitals, to say that when you change glove and you change the instrument, you are not losing money. Actually, you are making money, because the cost of a surgical site infection overshadow just a glove change. So if we conclude, gloves and instrument change reduce surgical site infection significantly. The effect was consistent in sensitivity analysis conducted. It was also consistent in subgroup analysis. So when we analyze elective versus emergency surgeries. So this paper, Cheetah, has been recently published in The Lancet. So those who can have access to full paper, you can come back again. You can have access to that link, and then you download the paper. It's free. Then you read it thoroughly to understand what are the details. So recommendation, we do recommend that we implement change in surgical practice by introducing a routine change in gloves and instruments when we are about to close abdominal incisions in clean contaminated, and dirty wounds. And then we incorporate that evidence into the national and international guidelines that we are drafting. So thank you very much.
Thank you very much, Prof. Faustin. For the purposes of avoiding moderators to need orthopedics or neurosurgery for torticollis, we're going to move the moderators ahead here. So I would like to call upon my colleague, Dr. Mirimbanyi Christophe, who is a general surgeon, but also an educator and kind of an addict to research. He's already published more than 20 papers and he's not stopping. So I want him to tell us about the Falcon study, which is also geared towards reducing surgical site infections in low and middle income countries. The floor is yours, 7 minutes. Thank you.
Okay, thank you, the moderator. Thank you for having me. And it is a great pleasure to be in front of you and share with you the result of one of the clinical trials that have been conducted globally, but also in Rwanda, led by the Global Surgery Hub Rwanda. As you know, the surgical site infection is a common postoperative complication, and the WHO guidelines recommends some of the intervention to reduce the surgical site infection, including the skin preparation and also the closure of the abdominal fascia. So this trial was conducted to test whether those two interventions can really change or reduce the surgical site infection rate. So there is no conflict of interest. This is a clinical trial that has been funded by NHR UK government, and it has been conducted globally under global collaboration, and Rwanda was also part of it, and it was conducted by the Global Surgery Hub Rwanda as the coordinating entity, and it has been conducted in 3 hospitals in our country: Sehashka, Chibogora and Chibung Referral Hospital. And the intervention is that's a 2x2 clinical trial saying that whether the skin preparation, you can do it using alcohol chlorhexidine, you can use povidone iodine, and also on the other hand, you can close the abdominal fascia using coated sutures versus non-coated suture. So this intervention, as I said, it was a 2x2, and it was seeing whether either of those two interventions may contribute in decreasing surgical site infection. The patients were included were those who underwent abdominal surgery. There were adults and children 12 years and above, and the abdominal incision was considered to be 5 centimeters and above, and there were emergence and elective cesarean sections included. The primary outcome was the rate of surgical site infection up to 30 days after surgery, and we defined the surgical site infection as superficial or deep SSI as CDC definition. During this clinical trial, the operator was not blinded, as he was the one operating and knowing what type of skin prep solutions will be used and also the type of suture to be used during the abdominal closure. However, those who were assessing the outcomes were blinded, and also the patient was blinded. They were masked on the whether the skin preparation type of the solution used or whether the suture was coated or non-coated. The sample size Tier 2 clinical trial initiation was at 35,480 cases, and they were including the clean surgery up to dirty surgery. And the planned subgroup analysis were targeting whether the surgery was emergency or whether it was elective, looking at the patient age, and also looking also at checklist completion during the surgery. This trial was conducted in 54 hospitals and 7 countries. As I said, in our country there were 3 hospitals that were included. And also I mentioned that Chibogola Hospital was among the top hospitals worldwide, including during this clinical trial recruitment. And 3,091 patient surgeries were clinically contaminated, and 2,697 contaminated and dirty. We found 86% were adults, and 67% of surgeries were emergencies, and 49% of incisions were midline incisions. When comparing to of clinical practice, we found that the checklist was used up to 88%, and the pulse oximetry measurements were at 98%, and antibiotic prophylaxis were given up to 95%, and the temperature monitoring during intraoperatively was at 30%, and the blood sugar was at 10%. This clinical trial have found that 22%, we had 22% of surgical site infection, and around 15% were found in clinically contaminated, and 30% were in contaminated or death group. And overall, there was no difference in terms of whether the solution that has been used or the closure of the suture, whether it was antibiotic coated or non-coated suture. So there was no difference in terms of the surgical site infection rate in both groups. The secondary outcome in this clinical trial was to look at the skin preparation and the fascial closure, and look at the mortality at 30 days postoperatively, or whether there was the unplanned the operation. And we have seen that there was no significant difference, and there was no significant difference in terms of the secondary outcome as well. And as a conclusion, we have seen that there was no evidence supporting either chlorhexidine or coated sutures would really decrease the surgical site infection. And of course, these results have a positive impact on the patient as well as evidence-based practice, and so that people would not say, because I don't have chlorhexidine, I need to get the povidone because it's the one which will really reduce the surgical site infection. Or saying, because I needed to close my abdominal incision, I need to get antibiotic-coated suture as to really decrease the surgical site infection compared to routine sutures with no antibiotic-coated that would be used to close. And it also helped in the global guidance, change the practice, and also it shows that the surgical site infection is still high. And I also take this point to tell you that after this clinical trial, it's where even the SHITA clinical trial was also initiated to see whether there's other intervention that would be undertaken to really decrease the surgical site infection. This paper has been published in a high quality journal and peer-reviewed journal, and it has been also presented in different international conferences, and it has been one of the clinical trials that has had a high rate globally among the published clinical trials. For those who would have the link for the publication, you can access it and have more details. Said that, I think these clinical trials are helping us to really review our practice and also align with the global standards in terms of surgical practice and outcome. Thank you.
Thank you, Dr. Christoph, and thank you for keeping the time. I will allow you to catch your breath before you introduce the other following presenter. So let me call upon Dr. Ronald Twasime. He's a consultant general surgeon from Kibogora Hospital. He likes to call him fondly a rural surgeon, which is truly true. And he's going to tell us about the Delphi prioritization and development of global surgery guidelines for the prevention of surgical site infection. We would think like we are back 4 years ago when our theme was surgical site infection, but it seems it's still coming up, and it's interesting that we have such great papers and studies that are being conducted to address this problem. So welcome, Dr. Ronald.
Thank you very much. I'm going to present on Delphi prioritization and development of global surgery guidelines for the prevention of surgical site infection. This is an article that was written by the National Institute of Health Research for Global Health Unit on Global Surgery. So I'm presenting on their behalf, and more dedication goes to Prof. Foste. He's doing a lot in including us and teaching us how to do research. So Kibogora would not have been mentioned probably. And it's written, it's an article that is published in the British Journal of Surgery. So maybe we can go and look for it after the presentation. So introduction, there's high-income countries develop clinical guidelines with evidence-based recommendation that aim at standardizing patient care by identifying best practice that would reduce complications, mortality, and hospital costs. And there is lack of these clinical guidelines to meet needs of health services in low-middle income countries, leading to inconsistency and potential benefits that are not fully realized. So there is need to streamline guidelines which can inform prioritization of implementation of key practical measures in low-middle income countries. The aim of this study was to prioritize topics for future global surgery guidelines and to develop guidelines for the top ranked topic. And in the method, you see that there are countries from low-income countries like Benin, Malawi, Rwanda, Zambia, and low-middle-income countries, Ghana, Guatemala, Egypt, India, Nigeria, Pakistan, Philippines, and upper-middle-income countries, Mexico, South Africa, South Asia, and others that were, their surgeons were involved in this article when they are doing meetings and prioritization. So prioritization of global surgery guidance topics, a 3-round Delphi exercise was conducted among the National Institute of Health Research Global Surgery Unit Network to prioritize topics. And in the first round, collaborators proposed guideline topics. And in the second round, an international panel shortlisted the top 12 proposed guideline topics. Then in the third round, an anonymous online vote by low-middle income country stakeholders, which are mostly surgeons, then prioritized the short-listed topics. The results, as you see in that table, they excluded topics and they remained with 12 topics. And all the 12 topics, you see that prevention of wound infection has the highest election. So a total of 56 surgeons from across 15 low-middle income countries proposed 34 guideline topics. The top 12 were shortlisted and then prioritized in an online vote by 736 participants representing 82 low-middle income countries. The overall top ranked topic was prevention of surgical site infection. So the steering committee refined the scope for this guideline by focusing now on pre-operative and intraoperative intervention aimed at reducing surgical site infection risk. So as you see, this is the sequence of how they went on eliminating those recommendations to reach at the few that will be used to prevent surgical site infection. So this is stage 0 research was done in 2008 to identify existing guidelines relevant to prevention of surgical site, and 5 eligible guidelines were identified. So there are many recommendations. From 160, they went on eliminating up to when they reached the least ones that were recommended at last. And you see that there are a lot of clinicians that were involved, 13 countries, 4 from low-middle income countries, 7 from low-income countries, 7 from low-middle income countries, and 2 from upper-middle income countries. So this involved surgeons, anesthetists, and 2 other specialists that were not identified. So 23 of the 45 participants were Rwandans. And remember this, there is a meeting that was held in 2019 here. So all this started here in our country. And 6 of the 45 were in rural setting, while 38 were from public hospitals. Of the 31 recommendations, only 19 proceeded to stage 2. Then in stage 2 again, 32 low-middle income country surgeons were invited, and 28 out of 32 responded, representing by 13 countries. So 17 out of 19 draft recommendations that came to the second stage had agreement from at least 75% respondents regarding the appropriateness in low-middle income countries setting of the recommendations. Two recommendations concerning antibiotic prophylaxis in clean surgery and wound edge protect devices were eliminated. So then they came to the third stage, and the panel included 12 low-middle income members from 10 countries as well as high-income country members. Combined the recommendation regarding the antibiotic prophylaxis for clean contaminated, and data. So based on the research clinical trial of WHO platform, 4 draft recommendations were changed to research recommendation. The panel agreed on the final list of 9 essential and 3 desirable clinical recommendations. It was agreed that the guidelines will be reviewed in 4 years. So when you see, these are the recommendations that were agreed upon that will be used in prevention of surgical site infection. So they are those ones that are essential. These ones are a must to everyone, wherever you're working. So the desirable, they are the ones that are really needed, but maybe where you're working, it's not. Maybe it's not like they are. It's not possible to apply them, or it's non applicable. But sometimes it's applicable. Sometimes it may not. But these ensure patients have a full body wash with clean water and soap before operation. Select antibiotic prophylaxis according to published local, regional, and national guidelines that take into account expected pathogens for operation type and local resistance patterns. Administer antibiotics to all patients undergoing clean, contaminated, or dirty surgery. Administer antibiotics prophylaxis intravenously within 60 minutes before the incision. Administer a repeated dose of antibiotics prophylaxis if the duration of operation is longer than the half-life of the antibiotic given. Do not routinely continue prophylactic antibiotic beyond 24 hours after operation for the purpose of reducing surgical site infection risk. Prepare the skin at the surgical site immediately before incision using antiseptic preparation. During surgery, under general anesthetic, provide supplemental oxygen to maintain adequate tissue perfusion, ensuring that the patient oxygen saturation is maintained at greater than 95%. If hair removal is required, this is sometimes applicable or not, is required, do this on the operating table immediately before the incision. Maintain normothermia above 35.5 degrees. And for all patients, monitor perioperative sugar levels and manage this according to a defined protocol. Now for future research, these ones, they are still in the research process, but they have not yet been agreed on. So research is required to test the effectiveness of routine antibiotic prophylaxis for reducing surgical site infection for patients undergoing clean surgery in low-middle income countries, and the results of ongoing research regarding the optimal solution for skin preparation should be monitored. Result of ongoing research for post-op supplemental oxygen should be monitored, and research on effectiveness of wound lavage for prevention of surgical site infection. So the study prioritized 12 recommendations for prevention of surgical site infection in abdominal surgery, which have been stratified as essential, as we have read. Challenges in low middle income countries could be reflected by adapting existing high income country guidelines and allow healthcare providers to prioritize implementation of key interventions that are most likely to benefit patients. And the role of low middle income clinicians as participants was to identify likely barriers to implementation and to prioritize recommendation based on the overall feasibility. And in the conclusion, surgical site infection is the commonest complication in abdominal surgery. Initiative to reduce it should be prioritized worldwide, mostly in low middle income countries. And this process led to the development of global surgery guideline for the prevention of surgical site infection that is both clinically relevant and implementable in low middle income settings. God bless you.
Thank you, Leonard, for a good presentation. May I call upon the next presenter, Dr. George Utibaruta, for the next presentation. Dr. George is a research associate at Imperial College London in the Faculty of Medicine, School of Public Health, Department of Epidemiology and Statistics. He holds a PhD in statistics from Mexico, and he has been one of the founder and the contributor in establishing Global Surgery Hub Rwanda, and also he's research collaborating in different researches, and we are happy to have him and present as the research conducted called Talon. Thank you. The floor is yours.
Thank you, Dr. Christoph, for the good introduction. So, first of all, I would like to thank the organizing committee for the invitation. And I will be presenting this study on behalf of the Global Surgery Research Hub Rwanda, so which is basically related to the previous studies that have been presented, Falcon and Cheetah. So, next slide, please. Taron is basically about to try to assess the surgical site infection remotely. So, like to do a follow-up, which not in person, but using the telephone calls. So, this is part of telemedicine. So basically, telemedicine has been used in a range of medicine area. So where people just try to facilitate patient or even the healthcare providers to give the health services in a cost-effective way, and also to facilitate sometimes people who should not be able to reach or to get in-person consultations or evaluations. Can you back, please? Back. Yes. Okay, thank you. As you know, so I want to put this in the context of Rwanda, even though this is an international study. So I want to put it in the context of Rwanda. So sometimes, as you know, the economic status of our population provide to even to get that kind of health services, because sometimes we live so far, we live in a remote area, so which sometimes is very difficult to come back to the hospital for the appointment or even to see our doctors. So one of these challenges that should be overcome was just to try to implement this study. So where, as I mentioned, it was just to try to see whether, so even though, as they mentioned it in Falcon, so the follow-up was up to 30 days after surgery. So this approach was just to try to contact people before that time. So then the results from the phone calls will be compared to the results in person assistant or in person checkup. Next. Now, no, wait. Okay, so as I already mentioned, so surgical site infection is probably more accurate when the people after the discharge. So because, as I mentioned, if we put it in the context of our population, so taking care back home is not easier, as you know, for our day life or what people do back in our rural areas. So next. Okay. So which was trying to help people just to not to come back or to just to not to spend much more money in coming back to the hospital. So basically the method used here was, as I mentioned, this was part of Falcon and the Cheetah. So this was a study within a trial. So patient was called. You tried to reach out many times to see. So once you reach the patient, so you should use this what we call wound healing questionnaire, which was adopted in the context of Rwanda, just to try to contact patient. Then after to go through the questionnaire or the questions you have, then after that you make score of what according to the patient had responded. Then we compare this one with the in-person checkup at the 30 days. Next. So these are some results. Maybe, I don't know if you can be able to see them. So, but I will try to highlight them. So as the Falcon or Cheetah were international study, so we had patients from different countries, obviously. So we have upper middle income countries. We had the patient from low middle income countries, and also the patient from low income countries. So in terms of telephone calls, contacts, so this was successful, by the way, because more than 90% of calls were successful. Only 9% they lost follow-up. So the other thing we can mention, so when people were trying to reach out to the patient, so for one intent, so we had up to 71% for one call. You will be able to find the patient. Then for 2 or 3 intents, so the percentage was 27%. So the overall contacts that have made were people, so if you compare urban areas and the rural areas, so we had 60% of people from urban area, and 35% were people from rural area. So the other thing, we try to understand whether people, they're using their own phones or they're using the phone from the family members or even for the neighbors. So if you, with that data, So we realized that patients who have been contacted, at least 64% were using their own phone, and the 33% they are using for other people's phones. So should be neighbor, should be a family member, and so on. So the other results, it was about which kind of phones that have been used. So the reason of this data was maybe to try to see if next time we should go beyond the just phone. Maybe we should try to implement the telemedicine or using a picture, as someone was mentioning here, just to assess the surgical site infection by using videos. So one of the risk factors we found out was about time. It was about these are the factors which was reducing the successful of getting the calls, of getting consultation through calls. So we had time, we had the SH grade. SH is the American Society Anesthesia score. Then the other one was about whether the approach was open midline or non-midline operations. So in terms of comparing the phone calls and the in-person consultation, so we realized that the phone call was very successful. As you see, for example, this operating characteristic curve operating receiver. So if we go through all those risk factor, you realize all the under curve was above 80%. So as closing remarks, so we realize that the remote follow-up is feasible. Also not about only for patient, also it will allow maybe the senior surgeon or senior medical provider to allow or to include the junior in terms of consultation by phone, of course. And also, this also will encourage or will improve or increase the training for our young surgeons. So the other thing is about community engagement, because if you allow a patient to assess his or her own wound, also will be a good thing, just where we'll be engaging our community in our healthcare services. Thank you.
Thank you, Dr. George, for a good presentation. May I call upon the last presenter for this session, the Emmanuel Espoir Mungura, Data Manager at Global Surgery Hub Rwanda, to give us the last presentation this session.
Thank you very much. I will present this micro study that was run by Global Surgery. So I'll be presenting it on behalf of Global Surgery. The study is called the WHO Checklist Safety, Usage and Compliance in Rwanda and Malawi. As for introduction, the WHO surgical safety checklist was developed in 2008, and it is a comprehensive list which has got 3 phases, as you know: the sign in and the timeout and the sign out, and also its implementation has significantly reduced morbidity and mortality. The aim of this study that I'm presenting is to assess its usage and compliance in Rwanda and Malawi. The method, let's go to the next slide. The method, this study has been conducted in 28 district hospital and referral hospitals, and it is a cross-sectional study which took place in the first week of June 2020. Two main parts of the study as the design. One was the observation, which was conducted during different procedures. A nurse, a data collector was there, and she was ticking if what is being complied to. And the study also comprised a survey where theater users, nurses, surgeons, and others, theater users, they were an interview. They had interviews. And for the observation, 602 cases were observed, and for the interviews, it's 632 interviews. For the results, the survey was done on different specialties, and 50% of the survey was done for obstetric and gynecology, and 32% was done on general surgery procedures, and 12.9% was done on for orthopedy. As for the observation, 49% was done in Malawi, and 50% was done in Rwanda. As for the availability of WHO surgical for WHO SS checklist, the availability is 69% of the cases. The WHO checklist was available, and it was absent for 30%. Another, I don't know if you could see the result. The first row is about the sign-in, and we compared different specialties. For general surgeon, it seems that the WHO surgery safety checklist was available more for general surgeon procedures compared to the rest. And it was more available in Rwanda, that is at the sign-in. It was more available in Rwanda compared to Malawi. At the timeout, the checklist was available more on elective cases compared to emergency, which I think is a bit obvious. As for also Rwanda, the checklist is available in Rwanda compared to Malawi at the timeout. And at the sign-out, the checklist was available at the same level for district and referral hospitals. Also, at the sign-out, it was more available in Rwanda compared to Malawi. I think I said this, that it was more used in Rwanda compared to Malawi. And the next slide, we ran a logistic regression to see factors influencing the usage or compliance to the checklist. And one of the variables that we found that mostly influence the usage of the checklist are experienced theater users. Either experienced nurses or experienced surgeons are more likely to comply to the usage of the checklist with that p-value. And also post-grad practitioners are more compliant compared to the rest of the theater users. And also the presence of the team at the timeout is a big factor that influences compliance to the usage of the checklist. Next. As a conclusion, I think I said it, training and high education influences the usage of the checklist, and also the availability of the team also influences the usage of the checklist. And also, it should be recommended to be used, obviously, and further studies can be done to enhance and assess more factors that influences the usage of the checklist. These are the references, and thank you very much for your attention.
Thank you very much, Mr. Ngabo, for that interesting study. So a plea for further education. So we have a very, very brief discussion. So 30 seconds per intervener, one question, and we take 5, and we head for lunch. So who is first? Prof, 30 seconds.
It's less than a second. I just appreciate all of you. The presentations are good. I just have one question with the pictures. Dr. George, there is a picture talking about it was taken in from Rwanda, which shows grass-thatched houses. I have an issue with that. I don't know when it was taken, because I'm trying to figure out, did our program of abolishing grass-thatched houses fail, or it was a mistaken picture? You can look at Dr. George's presentation. There is a picture which shows grass-thatched houses.
Yes, George, you can answer maybe?
I'm waiting for the picture he's talking about. So which one?
Maybe the pictures are a bit far. These are probably not glass. It looks like... yeah. Yeah.
So you mean the lights?
As you are reviewing, maybe the is it true or?
I didn't hear the. What is the question?
Is it in Nyakatsi? That's what he's asking.
Namategura.
Namategura. In Nyakatsi.
Yeah.
The question from Prof. Nkusi yabazaga n'imizi ari inzu z'ibyatsi, ariko iyo uzegere ntabwo ari inzu z'ibyatsi, ni inzu zitari nziza cyane, ariko mu Rwanda zirahari.
Yes, it's not glass touch. Okay, any other question in line? Dr. George? Yes, no question? Yes. Your name and one question.
Thank you very much. My question is to Professor Faustin. That RCT is very interesting. The one change of gloves and instruments before closure. But my question is, what is the uptake like in Rwanda, for instance? Let's look at Rwanda, not the other countries that participated, but what has been the uptake to the outcome of this research in Rwanda? Is it something that the Rwandan Surgical Society has recommended? Is it being practiced at every theater session, or you are still in the process of still advocating for this?
Thank you, Dr. Abiola. So actually this is, the session like this serve for dissemination. So this is a new study. So we published these findings 1 month ago, actually in November. And October. So this is the first kind of gathering that we are sharing these results, and that's why we think this is a very good timing to talk to surgeons and then next to the decision makers to make them aware that these are the findings. So we as researchers, we have to move from just being happy that our papers are accepted in good journals, but try to translate that into policies and practice. So this is the journey which is starting, and I really recommend to implement that. So next time when we meet, we will respond to that question. So we will measure the uptake and see who is implementing this. So thank you very much.
Thank you, Prof. 2 more questions? Or 3? Yes, Dr. George, you have a mic.
Thank you. Maybe it's just it's not a question, it's just kind of a comment. We are talking about research, so I think research should start in our own everyday lives. So in terms of our senior lecturers who are here or senior surgeon, so how, maybe this will be a question, yeah. How will be, or how do we include, or do we encourage our junior surgeon in what we do everyday lives? So what this means, so sometimes we publish our work, we publish them in the good journals, but how are we involving in those young researchers, those young or senior or junior surgeon in what we do in our teaching session activities? Sometimes we refer someone else's work or study, but I think we should just start to make references during our teaching sessions to what we do to our students. Maybe this also should encourage our students to be involved in research.
Thank you, George. I think you are joining the call that has been made by many, including the actual trainees that are in the programs. So there is need for more mentorship and involvement of the trainees, and I think institutes like the Hub are part of this process of getting people involved. As you've seen, there is more inclusion. Any other question to the presenters? So without any due delay, so I will hand back the microphone to the Musanjiza Magambo. So please.
Thank you very much. Another round of applause for the panelists and the moderators. So I think the next session was awaited by many people. And we have 2 moderators, Ms. Clementine and Aurore, that will take us to the next session that will take place in 2 different places, but will share the same presentation. So please follow Ms. Clementine and Aurore. They're on the back. We'll be going through the main entrance, and we shall be coming back within 30 minutes. Thank you, and enjoy your presentation. Enjoyed the last session. Some are still enjoying it, and I hope that you clapped for the moderators there. So, without further ado, while we are also preparing the next sessions, we would like to welcome one of the stakeholders of the conference with the manufacturer BioLitech. We'd like to welcome Ms. Mary Najuma for a presentation, and they are focused usually on laser surgery. So it's mostly interesting for general surgeons with regards to hemorrhoids or any venous insufficiencies. Let's give the floor to Ms. Najuma. Thank you.
Thank you very much, Mr. MC. Good afternoon, ladies and gentlemen. Thank you so much for giving us this opportunity to speak to you about laser surgery. My name is Mary Najuma. I'm representing BioLitech. BioLitech is a German manufacturer of surgical applications. We are here to extend an arm to Rwanda. We're already established in Uganda. Surgeries are already going on there. We've been in Uganda since 2019. And we thought of Rwanda, since Rwanda is a sister country to Uganda. So that's why we are here today, to introduce and then begin a relationship with you. Yeah, please, next slide. BioLitech is a manufacturer of biomedical technologies, like I said, and we are based in minimally invasive applications. So today, the kind of laser that I want to introduce to you, I know you've heard of laser surgery before, the CO2 laser, the neo laser, but ours is none of those. Ours is a diode laser. So I want to show you the applications in which it can be used, so you see in your different specialties where it can help you to give better service to your clients. So I'll go to the first, which is in proctology. We have like 3 uses in proctology. The first one is laser hemorrhoidoplasty, where you just use a laser fiber, and we have a laser generator. Instead of you cutting or using a stapler, you just give laser energy into the hemorrhoid cushion and you shrink it. So 30% of the shrinkage happens during surgery, but for the next 6 weeks, we keep seeing ongoing recovery until someone completely recovers. So the advantage is we're going to maintain, he has moved. We're going to retain the anal sphincters and intact. We will have quick healing and return to work, minimal pain, and then also it's cost effective. The things that you will use in the surgery will be less than when you do an open surgery. So next we have, and it can work on all stages of hemorrhoids. We are happy to train the surgeons in how to use it in the different ways. We have its application as well in fistulas, anal fistulas. We still have laser applications there. Then pyelonoidal cysts, they're not very common in Africans, but they are there. So you could also use laser energy to seal them off, to seal off fistula tracts, to seal off pyelonoidal cysts. So that's it with proctology. Then we go to the next and next and next. Then next is we have some application in spine surgery, orthopedics, where people suffer so much from sciatica pain, disc prolapses. With a stage 1 and a stage 2, you can actually enter into the space, give laser energy, and relieve the symptoms. As you see the surgeons that are interested, we have a table behind. You get in touch with us, and then we go ahead to see how we can arrange to have trainings and take this further. So that's it with spine. Let's go to the next. The next is in the veins, vascular surgeons, where we have incompetent veins, and we know the famous stripping that we do. Here, laser is giving us a new era where we don't need to cut and strip. We just need to have a small entry point into the vein where the great saphenous or the small saphenous, and then we give energy according to vein diameter. We have to do some investigation definitely on the vein. And then we just give energy, ablate the vein, seal it off. So this is also another application. That's vascular surgery. Let's go to the next. The next is urology. In urology, we also have various applications, bladder tumors, BPH treatment, where you do TURP. You can use laser, and you do prostate vaporization. And there are enormous advantages with that compared to when you would do a TURP. And then for the condylomas, for strictures as well. So details we will give to the interested surgeons, and then we're interested in training you for free. Yeah? So that you get the technology and be able to use it to the people of Rwanda and even globally. So those are 4 that we're interested in sharing today. But we have other applications in thoracic surgery. We have aesthetic surgeries. But for today, we're interested in sharing the 4, since it's the beginning. And then we take it on from there. Thank you very much. That brings us to the end of the presentation. I welcome like 1 or 2 questions if they are there.
What's the level of investment, for example, in urology?
In urology, the level of investment, we first of all need to acquire a laser generator. And then also for every patient, we have consumables. That's the laser fiber. So then the details of how much, really we would like to discuss them with individuals. Yeah, we don't want to scare you or to give you false hope, but it's affordable. That's what I can say. And the returns are really good. Yeah. Any more questions?
The disc you said it's lumbar. So, as you said, we can discuss that. No, I was asking about the vaporization of a disc. Definitely you're going to go posterior, isn't it? Okay. Do we have studies about?
We've shared a few brochures. They have like 1 or 2, but also for the interested surgeons, we can also still share with you more of a few studies. There are not very many for the PLDD, that's what I can tell you, but there are a few studies that have been done and proven. Yes.
Okay, so we'll take it from there.
Thank you.
Thank you very much.
I think my minutes are done. Thank you so much. We'll be glad to be in touch. Please, you can display the contact. I think I have a minute for people to see. And then also at our desk, we have the contacts. And the brochures on the tables, we try to stick some cards. For further, we are so interested in extending this to Rwanda and training the surgeons. And since you're doing education, you could also train the juniors that are coming so that it doesn't sound so new when it comes. Thank you.
Thank you very much. I think this is a very interesting presentation, and also a heads up to the newly graduates and future graduates from surgery. It's also an important thing to remember that this is the time to truly be networking with the manufacturer and to know what is it that we can afford in terms of material or equipment, but also to make it affordable for our patients. So this is the right time to advocate for this. And I would like to welcome the next session. It will be also a presentation. I would like for the moderators to come in. We'll be with Dr. Jogoza Izai from CHK, the ENT surgeon and head of department of ENT. And he will try his best to keep time without any pressure. I would like also to welcome maybe Dr. Ngarambe Christian to be among the moderators. Thank you.
Thank you, Dr. Miguel. The next session is still in evidence-based. Now we are going to talk about COVID and surgical practice. To catch up with time, I would like to call the next presenter, and is Christophe Mpirimbanyi, has been presented. We don't lose our time. Chris, where is Chris? So this will be short. It's we have 4 presentations. I think it won't take time. We need to catch up with time. So you have 10 minutes, Dr. Chris. He has been presented. We don't go through another introduction.
Okay, thank you, the moderator. It's a great pleasure to be again in front of you to share with you the result of the study we conducted, which is on the impact of COVID-19 on surgical care in Rwanda, and it is almost at the final stage. We are now drafting the manuscript for publication. It is a study that has been funded by the government of Rwanda via National Council of Science and Technology, and it's the first grant that Rwanda Surgical Society has won. And, I'm presenting on behalf of the team that we are working together on this project. The COVID-19 had impacted and different health factors, including surgery as well. And in some areas of the world, even in Rwanda included, some elective cases were cancelled, and even outpatient clinic to prioritize the resources for COVID-19 patients, which were increasing, as well as to decrease the risk of health professionals, the patient, for getting this pandemic. And in Rwanda, access to surgical care is, as you know, is limited by the sufficient workforce, and we still have a very long backlog of surgical cases that need a surgical care. So the aim of this study was to assess the impact of surgery during this pandemic period, and we wanted to find out whether we've taken 2 periods, 1 year prior to COVID and the year during the COVID, and we have assessed the number of outpatient consultations. We have also assessed the number of surgical volumes, and also we have gone through different specialties and see whether there have been any decrease due to this pandemic. It was a multi-center nationwide cross-sectional study conducted in 22 hospitals, public and private, and we collected data on the surgery performed, the number of surgical outpatients per specialty, and we also took qualitative data on to know the challenges that were met by the surgical care providers during that period. As the result, we have seen that in the pre-COVID year area and in the COVID year, there was a slight decrease, but it's not significant. In terms of surgery, in the pre-COVID area, the emergencies has increased compared to pre-COVID area because in the COVID area, the emergency cases were given priority and they were being transferred easily. But for elective cases, there were also in some areas the elective cases increased as well, because patients were getting care near to their facilities, but the transfers have decreased. When we compare different specialties, we've seen there are some specialties that had decreased cases, number of cases, mainly the orthopedic cases. This is due to the fact that there was limited travel, and other specialties, there were increase in elective cases because it was a time for them to really manage those elective cases that they didn't have time to manage during the normal circumstances. And the surgeons were on the site and they were able to perform those surgery and ready to increase in some specialties for elective cases. And when you go to all specialties, there were some where the elective were more increased compared to emergencies. But when you compare the COVID, the time lockdown, total country lockdown and the district lockdown, we found that in the COVID year, there was an increase of cases that were consulted on daily basis, but when we go to country lockdown, the number has decreased. And when we looked on the outpatient per specialty and across different period, COVID year, country lockdown and district lockdown, we found that there was no increase, the numbers were still static. And this goes along all specialties. But when we come to surgical volume during the COVID, in normal circumstances, we found that the cesarean sections in the country lockdown, the cases has increased compared to pre-COVID area. But for the most common performed procedures, of course, was C-section. The others were urological procedures, that was pediatric umbilical hernia repairs, and adult inguinal hernia repairs were the main top procedures that were performed, as well as the laparoscopy for general surgery. But the number of procedures increased in the total lockdown compared to pre-COVID area. And in terms of ICU disposition, there was no significant difference when comparing pre-COVID to COVID area, because here there was no change in terms of the beds, that the facilities, and we know that what has been done is that COVID cases were relocated to a specific center, and that didn't have really a big impact on the irregular ICU postoperative case admissions. This was the same across the total country lockdown and district lockdown. And when you compare the length of hospital stay, there in some specialties, we have found that in the COVID year, the average, per day, the median was 3 days of hospital stay, and it was the same across whether it was in the total, in the COVID year, country lockdown, whether or district lockdown. However, when you go to specialties, we found that there are some cases where the hospital stay were higher due to the fact that, especially in the country lockdown, because some cases could not, there was no possibility for patients to go back to their homes. So some of the challenges that the surgical care providers faced, or the patients were missing appointment due to failure to reach their health facility. There was a shortage of hospital staff because some were relocated to COVID area, and there was also unavailability of beds due to prioritization of COVID-19, and those are the mainly. But as a summary, statistical summary, you have found that the overall cases, there was no statistical significance, but when you compare the COVID period versus district lockdown, there was a significance in terms of overall inpatient cases, and the hospital stay, the only in the country lockdown, it's where there was increase, as I said, because cases, those who were managed, they could not even go back, find the means to go back to their districts. And when you compare to status at discharge, there was the significance difference between the district lockdown versus COVID here. As conclusion, COVID-19 has negatively affected the healthcare system and surgical care delivery, and this project has remoted the effects on surgical care in terms of surgical care delivery, which was mainly related to decrease of number of consultations, delay in ending surgical care, and mainly in the district strict lockdown laws implemented could not allow patients to move and get surgical care easily. And we are also, we think this will help us also to use other published guidelines, international guidelines, and have a local guideline that would help us to be prepared when there is any other arising pandemic in the future. Thank you.
Thank you, Dr. Christoph, for the good presentation in your respected time. Again, the line of impact of COVID, I would like to call upon the next presenter, who is Emmanuel Munyaneza. Munyaneza is going to talk about timing of surgery following COVID infection. It's an international prospective cohort study. Munyaneza is the coordinator of undergraduate and postgraduate training at CHK, and is also the coordinator of community engagement and involvement at Global Search Hub Rwanda. You are welcome.
Thank you, moderator. Ladies and gentlemen, good afternoon. It's a great pleasure for me to be here presenting the study, the findings from this study titled Timing of Surgery Following SARS COVID-2 Infection. This study was multi-center international prospective cohort study that was conducted by Global Surgery Research Hub Rwanda in collaboration with COVID Surge Collaborative and the Global Surgery Collaborative, NIHR Global Surgery Unity. As a background, as all of us we know, patients with perioperative SARS COVID-2 infection were at a high risk of developing postoperative complication, even death. As the cumulative number of people who were being infected by this kind of infection, there was a need to know at how long time or when can we operate a patient after having this infection, and we at least we expect some few complications postoperatively. That's why the primary outcome was measuring 30-day postoperative mortality. As methods, this, as I was saying, this was multi-center international prospective cohort study that was conducted in 2020 The data collection was done by having or by recruiting patient operated within 7 days consecutively. Each hospital was requested to recruit consecutive patient operated within 1 week. And inclusion criteria, any surgery, either emergency or elective, patients were included, but main exposure was those patients having this SARS-CoV-2 infection. The outcome, as I was saying, the primary was measuring 30-day mortality, while the second one was measuring or was assessing the post-operative complications, including pneumonia and the other complication that patient was or were having. Participation, as I was saying, that this was a multi-center international cohort study. We recruited 140,231 patients from 1,674 hospitals, and those hospitals were coming from 116 countries, whereby 15,015 collaborators have participated in this study. As a result, I can start on the demographics, where I can summarize demographics of our participants in 3 categories. If we start looking at the infection, the existence of infection or not, where all patients who have been recruited, among them only 2.2% were having the SARS-CoV-2 infection during the time of operation. When we compare the participant in terms of from when the patient was having the COVID-2 infection, comparing the time we are in, I mean the time where patient is coming to be operated, many patients, or 36.4, were in between 0 to 2 weeks after having that infection, then they present to the hospital for having the surgery. And another big number of patients were above 7 weeks, comparing the time where they were infected by this infection. When we compare the existing of symptoms or not, 44.5% of patients were asymptomatic, and 41.8% the patient were having symptoms, and 13.7% were still having the ongoing symptoms. As a result, among the total patients we recruited from 116 countries, 2.2 were having SARS-CoV-2 infection during the time of operation, and adjusted 30-day mortality in patient with SARS-CoV-2 infection was 1.5, which was 95, and the confidence interval was 1.4. So this means that if we take the patient who have been operated, and as I was saying, the primary outcome was to measure the post-operative mortality rate. Among those patients who were negative about this infection during the time of operation, only 1.5, the mortality was at 1.5. In a patient with a pre-operative SARS-CoV-2 infection diagnosis, mortality was increased in a patient having surgery within 0 to 2 weeks, 3 to 4 weeks, and 5 to 6 weeks consecutively. So this means that if you operate a patient when he's in between 0 to 2 weeks after having this infection, then we operate the patient, there is a high risk of death and even some pulmonary complication. Surgery performed less than, or more than, not less than, more than 7 weeks after SARS-CoV-2 infection was associated with a similar mortality risk to a baseline. This means that among those patients who were not having the infection, SARS-CoV-2 infection, we found that the mortality was at 1.5. And if we operate patients who have had the SARS-CoV-2 infection, but we operate them after 7 weeks, 7 weeks of having this infection, the mortality is the similar as in those patients without COVID-2 infection. After 7 weeks delay in undertaking surgery following SARS-CoV-2 infection, patient with ongoing symptom had a higher mortality than patient whose symptom had resolved or had been asymptomatic, as you can see. As a discussion, patient operated within 6 weeks of SARS-CoV-2 infection diagnosis were at increased risk of 30-day postoperative mortality and 30-day postoperative pulmonary complication. Therefore, surgery should be delayed for at least 7 weeks following SARS-CoV-2 infection to reduce the risk of mortality, even pulmonary complication. Our findings, we have found that the preoperative SARS-CoV-2 infection increases the risk of postoperative mortality and pulmonary complication. And this is the first study that was providing the findings about this phenomena. There was no other study during this time to compare the findings, as you can all know that this is a new pandemic that was not having a lot of study done. The greater granularity in this analysis compared with previous study has enabled more than 7 weeks to be determined as the optimal cutoff. Conclusion: we performed an international multi-center prospective cohort study that has recruited this number of patients, and we found that the risk of postoperative morbidity and mortality are greatest if patients are operated within 6 weeks of diagnosis of SARS-CoV-2 infection. Therefore, patients with ongoing symptoms at more than 7 weeks from diagnosis may benefit from further delay. As a recommendation or take-home message, in a patient with preoperative SARS-CoV-2 infection, where possible, delay surgery for at least 7 weeks. Patient with ongoing symptom, more than 7 weeks from diagnosis may benefit from further delay. Thank you very much.
Thank you very much, Mr. Munyaneza Emmanuel. Let's take one of our moderator for this session, Dr. Chogoza Izai, Head of Department ENT, to come for the 2 consecutive presentations. Thank you.
Thank you, Christian. I'm no longer the head of department. My head of department is there, but we work together. So in the line of impact of COVID, I would like to share this paper published in Lancet. It's about the mortality and pulmonary complications in patients undergoing surgery with perioperative COVID infection. It's an international cohort study by Global Surge and the COVID Surge Collaborative. As introduction, surgical patients represent a vulnerable patient group. First of all, due to physiological insert of an operation, mechanical ventilation, or underlying comorbidities. Before the pandemic, the rate of post-op pulmonary complication was from 1 to 10%, and the mortality associated was up to 3%. The reason why we did this surgery to see the mortality in the pandemic era. So this study is an international mid-center cohort study, and including patients who underwent surgery after contracting the virus within 7 days before or 30 days after surgery. And the test was done by PCR or by imaging or based on the clinical presentation. So the outcome, next slide please. We are not using the same. I have two presentations. One is this paper, the one is linked ongoing trial. So you are projecting the ongoing trial. Can you have another, they presented the paper? That one. So next slide, next. So I was there. So the outcome was the 30 days mortality and 30 days pulmonary complications. This study involved 1,129 patients who met the criteria, meaning 30 days mortality, 30 days follow-up, and it was done in 235 hospitals across 24 countries, and involved 1,200 collaborators around the world. So as a result, patients who had a positive infection and preoperatively were 26%, and diagnoses were done either by PCR or imaging in 94%, and most procedures were emergence in 74%, and the diagnoses were benign diseases in 55%, and the remaining were cancer and trauma, and the procedures were mainly gastrointestinal procedures with 33%. So the 30 days mortality rate, in general, the mortality rate was 23.8%. And mainly was in emergent surgeries with 74%, with a mortality of 25.6%. And most of them were in infection were identified in preoperative, in postoperative diagnosis, in postoperative in 71%, with a mortality of 25.6%. When we see the majority were pulmonary complications compared to no pulmonary complications, the pulmonary complications were 51.2%, and were either pneumonia, acute respiratory distress syndrome, or unexpected ventilation. When we see the risk factors, we see that more than patients aged more than 70 years and older were more affected with the 30 days mortality rate, and mainly emergency surgeries compared to elective surgeries. Patients aged 70 years and older are twice more likely to die than the ones less than 70. And the other risk included ASA grade, where the grade 3 to 5 were more associated with 30 days mortality rate, and diagnosis where the cancers were more at risk compared to benign diseases. There were also surgery being elective or emergency, where the patient who were underwent surgery as emergency were more affected with 30 days mortality rate. And when we compare the major versus the minor surgeries, we see that the major were more associated with risk, And the postoperative surgeries were less associated with mortality, 30 days mortality rate. So in conclusion, high overall mortality was observed with 24%, and most of them were pulmonary complication, where the pulmonary complication rate was 51%, and most death, almost 83%, were following pulmonary complications, and patients aged more than 70 years were operated as emergency or elective, were at high risk. And the take-home message is that during this pandemic era, the threshold for surgery should be raised, and all patients are at risk than in pre-COVID era, and consideration should be given for postponing non-critical case and opt for non-operative treatment or delay surgeries where needed. So this paper took us as global surgery to initiate a trial which is now ongoing. So it's a trial that I'm going to go through quickly. It's a trial entitled Protect Surge. No, the next. So Protect Surge is ongoing in our country. It was initiated based on this mortality linked to pulmonary complications. And the aim is to administer a drug prospectively in interventional arms and to see if it can prevent pulmonary complication in adult surgical patients at risk of COVID-19. And the objectives, next. The objective the main objectives is to provide reliable data on the effect of this prophylactic treatment on postoperative pulmonary complications. And the secondary objective is to assess the effect of the study treatment on postoperative proven COVID-19 pulmonary complications, to see the overall infected rate, the hospital stay, the pulmonary function, and safety and or tolerability of study treatment. So we have two arms. One is the control, which is normal practice, and another one is this RESP 301, which is inhaled nitric oxide generating solution. And the patient is randomized, operated, and information recorded on treatment, at discharge, and at 30 days follow-up. So how is the eligibility? The eligibility for hospitals are hospitals at least who recorded at least one case of COVID and performing elective and emergency adult surgery. And in Rwanda, we decided to take 5 hospitals who has been involved in previous clinical trials run by Global Surge Hub Rwanda. And eligible surgery include abdominal surgeries. So for patient eligibility, there are patients aged 18 years and more, abdominal surgeries, general anesthesia, asymptomatic of COVID-19 infection, including even the positive, but without symptoms, and who decide to give consent. So we exclude the local anesthesia, symptomatic patient with symptoms, allergies to interventional drug, and pregnant women, those unable to use a nebulizer, the ones with history of methemoglobin, or the ones on treatment with the same molecules. So patients have to give consent, and the randomization, as I said, it's in two arms, control and this nitric oxide generating solution. And patient is randomized on the day of surgery while he's in the hospital, and randomization is done using red cap. So the control is normal practice. Patient does not receive any interventional drug. And the second arm is this RISP-301, which contain nitric oxide, mannitol, and citric acid. And this is given by nebulization, and it is done 3 times per day. This is done for 7 days, or at discharge, whichever comes first. So as I said, it's an inhaled nitric oxide generating solution, which has shown effect against respiratory viruses, including COVID and other influenzas and some bacteria. And the sample size, actually this adaptive platform does not have a sample size, but we choose 200 in one in interventional arm and 200 in control. So we expect the outcome. The outcome is any patient developing postoperative pulmonary complication. The secondary outcome will be unexpected ventilation, proven pulmonary complications, infected rate, duration of hospital stay, and the pulmonary function. So this is where we stuck when we are running this trial, is when to record information. Information is recorded at trial entry, meaning we check eligibility, we sign consent, we randomize, we do pre-operative, pre and intraoperative assessment, mainly including a COVID test, and we start the drug in the morning of surgery and continue up to 7 days, whichever comes first, meaning discharge or at 7 days. And we monitor during treatment by doing hemostasis, platelet function, methemoglobin levels. Then we record information throughout the process up to 30 days. And we have also to report the serious adverse event when it's required. So at the time of follow-up, we have to record all information, including the contact of the patient, so that we cannot lose the patient at 30 days follow-up. And the 30 days follow-up is done by a telephone call. So we have to report the serious adverse event at before 24 hours once it occurs. And as you know, the evidence are still emerging. I can just mention that we started by even the antiretroviral drugs, then with hydroxychloroquine. Now we are on RISP-301. So anything which happens, we have to change the protocol and request for amendment. Now, the progress is that we have started the recruitment at CHK in May 2022, and continued at Kibagabaga in June, and Chibogora in August. Until now, we have recruited in the 2 arms, we have recruited 90 patients, and soon we move to CHUB and the Ruhengeri Referral Hospital, and we've even started the site initiation of visits. So the trial is run here by the principal investigator is Professor Faustin, and I'm PI, and we have a team from Birmingham, which is in charge of this trial. Thank you so much for your kind attention.
Thank you very much, Dr. Isai, for keeping the time for the two presentations. Time for questions and answers for our presenters.
Thank you, moderator. Thank you, presenters, for nice presentations. And actually, I really recommend the good job that you put together to produce these wonderful presentations. So mine is not a question, it's a number of comments. So I want to come back to the COVID surge presentation shared by Emmanuel. COVID surge, as you saw, is one of the biggest study ever conducted. So it puts together around 140,000 patients. And it has been conducted in above 160 countries and put together 40,000 collaborators. And actually that study got a Guinness record of the study which got the most authors on that paper. So we are 15,000. So that is being said because I want this to be shared with the Rwanda surgical community. So individual studies are okay, but they are being phased out. So we have to be joining the world community, the global community when we do research, so that we bring on board the strong evidences. So that's why I'm really calling the colleagues who want to join us in global surgery in our hub. So the doors are open. So anyone who wants to join tomorrow or today, just drop an email to me or to one of the deputies or the coordinators so that we know who is willing to join. So that tomorrow when we prioritize or we discuss things, we care for you as well. Because we do all this for all of us. It's not a closed kind of cycle. It's quite open. So please join and you are welcome. So now the question to the presenter. I'm going to help him joining us in another the community engagement and involvement, and especially how can we, in such big studies, be sure that the desiderata of the community and the patients are taken care of. So that's the question to Emmanuel, who is coordinating our community engagement. So because we are now moving away doing research for the community, but doing research with the community. So this is something I'm really keen on. So Emmanuel, how do we be sure that these big studies, as you saw how we organize them, they ask a lot of logistics and a lot of people are running so that they are not left behind. So how do we make sure that the community is taken care of and the community is engaged and involved from the beginning?
Thank you, Prof. Faustin, for asking this important question. Let me take this opportunity to inform everyone that community engagement and involvement is one directorate in the Global Surgery Unity Research Hub Rwanda. We are trying to change the way we were conducting studies. As you know, researcher may sit in his house or in his or her office, then choosing a topic, then developing the research throughout our research process, then until he get findings, then he go to the community telling them that I've found that this, if you do this in this way, it can change this and that. So actually, this new approach of involving the community is to try to couch or to involve or to attract the community so that we get their input from choosing topic, then we develop the topic, or we go throughout all research processes together without lefting them behind. Otherwise, if we go there, then we inform them, this is our findings, so you are obliged to do this and that. They may not implement your recommendations. So now, in whatever we are doing currently, we are trying to involve the community from the starting point, whereby we go there, we go in the community, then we have a meeting, we discuss what can you suggest us as priority in this community in terms of surgery, of course. It's where we have started. So currently we have 13 hospitals that are in our network. So in each hospital we established a steering committee which is composed by around 5 to 7 people from the community, and those people are expected to provide input during choosing topic, developing. Of course, we mentor them how to choose topic, how to prioritize, how to conduct research, how to do data collection in all steps. It's what we are planning to do in our Global Surgery Research Hub Rwanda. We are starting this new system of involving the community currently. Thank you.
Thank you very much, Mr. Munyaneza Emmanuel. So we are handing over the speech to the MC of the today, because of the time. They are not. We shall keep discussing the questions in the other sessions. Thank you very much.
Thank you very much. Another round of applause for the moderators. Thank you again. And as we continue, we will be now welcoming another stakeholders, one of the main stakeholders of the conference, coming from the RBC. He'll be now presenting on behalf of RBC. I think Dr. Simeon is around. They will be presenting briefly on HIV, STIs, and viral hepatitis, the current status of it in our country. So please welcome Dr. Trishimile Simeon. Thank you.
Thank you, MC, and I'm very glad to be here in this conference. I know I may be taking you through some of the subjects you are not concentrating much on, but I think all of those are the disease or further issues of the clients we share. So this is a brief discussion about the HIV. I know some of your clients may also be HIV positive, and you need to notice this one, and maybe do not just concentrate on surgery and forget that HIV is still there. We still have HIV. I think the slides are moving. And also not only this HIV, but also the viral hepatitis as well. So we take this few minutes for opportunity to share with you what we are doing with under HIV program. And as you can see over this screen, on the protected country profile, we still have like a prevalence of HIV at 3% countrywide in general population, and also quite incidence of the new cases around 8 per 10,000 person years. And we might also be able to notice the difference, the gender disparities between the female and the male, especially from those with younger age, as you can see. And when you are testing, we are also helping us different opportunities to get clients who are also being missed. And through even your usual consultations from the surgical officers, you can also still identify those who can be potentially HIV positive or even need like those services around. So we, under provider-initiated testing, we encourage all healthcare providers to take part of this, and maybe those clients who may also not willing or even having some issues to get tested to be linked to the HIV program, so that they can be benefiting the services available, like care and treatment services. I think if someone is operating on a patient with HIV, should be better or stable, if comfortable if they are having like someone is having a viral suppression, because the transmission rate also might be very minimized. Those are just from some of the differences or some of the subpopulation which we are concentrating on, and some other cases, some other strategies we are emphasizing on to get those clients who are HIV positive. Just maybe pulling out those who may be like hard to reach population or hard to reach clients, and then to bring them into our program. We have even some of those like identifying research testing, to be able to identify those high-risk group who are being affected by the HIV. And then those might be well encouraged by the clients themselves, their peers, but also a big part is played by the healthcare providers in all subject of practice. The mother-to-child transmission is focused as a subject to be eliminated. Like we are now having a target to eliminate the mother-to-child transmission, a vertical transmission of HIV, but we know it is still under a process where we need to emphasize, and maybe even if we are having less than 2% of the HIV prevalence or HIV prevalence, HIV seropositivity among the children born to mothers infected, but we still have like to lower those to eliminated or even zero infection from those children. And out of those being tested, we are even focusing that they may be also receive some services against the prevention, prophylaxis, and whatever. We also take part to encourage you to maybe help us even join some other prevention measures, including the voluntary medical male circumcision. I know this is where surgeons also do play a very big part in prevention. When we know that HIV can be prevented at 60% rate if someone is circumcised versus a non-circumcised person. And then we say we should also encourage those who are not circumcised to be circumcised, especially for those who are, for those men who are aged, who are like above 30 years or 40 years, who are very hard to reach. Nowadays, we are finding much more the young than the aged population. So all those population we are finding, pulling them to get to into the HIV program to be put on antiretroviral treatment, and they have a good rate of them being on the antiretroviral treatment. Of course, we are focusing much on the less intensive models. We do not want our clients to be much more frequently bringing or coming to the health facilities, but rather we need them to be stable and get to their work or do everything else. If they're having like some other offices or to consult, they should also take part of that, but without making them regular visits to the health facilities. So to the retention, we do not have issues. Many of the clients are retained, but we still need to emphasize and convince them that they should be on treatment. If you happen to find a client who is also HIV positive, whether it's undergoing a surgical condition and surgical follow-up, it might be also a good point to ask him if him or her if he or she is suppressing the viral load, because this is the goal of the treatment, or the goal to have known that you are HIV positive, you should be taking that action. And a number of them are suppressing, apart from those children living with HIV and even some other youth who have like separate or some other different conditions or different issues aligning with the HIV itself. Regarding the hepatitis B, I think every healthcare provider should have been vaccinated. If they are not, they should get to link with us to get vaccinated for against the hepatitis B, so that we may reduce those cases. But we also have those clients who are confirmed hepatitis B positive and also having a viral load that meets the criteria to be put on treatment. However, we are also even targeting the triple elimination of HIV, hepatitis C, and even syphilis, which I think we even have an inclusion of the hepatitis C as we are eliminating, but for those plans who are. For another point of information, if you have like a room to or a risk of exposure to HIV and hepatitis B and C, hepatitis C might be 20 times more risky to more than HIV on the same exposure you can get, and hepatitis B is estimated to be around even 100 times more than HIV. So you can understand that you need still to be emphasizing on this if you're known, but also all those clients who are HIV, who are hepatitis B, hepatitis C positive should also be receiving an effective treatment as well as like to be able to complete their treatment regimens. So I know it might be like cases or even some of the topics you do not have like a familiar being linked to, but they are on the same client whom you are having in offices or in your operating theaters. We a little bit mentioned on the sexually transmitted infections. Those are not really much more frequent in surgery, but I know they can be also those clients who need some other conditions, and we do under HIV program emphasize on those also to prevent those, and even having like an effective treatment for those clients who may be having those issues. Those are our major, okay, I don't know if the slides are still being running, but we have major identified the gaps, including the poor treatment outcomes for our clients. Maybe, so I don't know if my slides I'm having here are the same, but I was on the saying to the major identified gaps on the priorities of the population we are having, slide 23. So we are facing the poor treatment among children and adolescents. Again, we should enhance on the adolescent and the other key population to be on treatment as well as effectively being managed. And the prevention of mother-to-child transmission, as I said, and also focusing on decreased funding. We are having continuously the decreased funding of the HIV program, which used to be much more funded, but we still have like a room to all call for action or even for some other advocacies to get there in our program. Next slide. We have also to emphasize on the those identified knowledge gap between the youth and some other population who have been well trained or even informed well, and also reducing those causing the poor treatment outcomes in all the groups we are having. In conclusion or summary, we have to be aware of the HIV prevention measures available and also being effective to use those, to optimize those to, according to our population needs. And also contribute to evidence generation between generating evidence-based approaches in our settings where we are performing, we are exercising, and also try to link with the community approaches, some of the community approaches with that need like support to the clients, or even some of the healthcare workers, because when someone is treated from a health facility, definitely need to be back in the community, and this where we will also be having some others coming from. And again, those who are tested positive should be linked to treatment and be on effective treatment and remain there, return to that one, including even the monitoring for their drugs or even their effectiveness. Otherwise, we could be not doing well if you're finding only the disease is there, but we're not doing good on the monitoring or even the retention of the treatment. So without taking further time of yours, I would limit myself here, and thank you very much, and welcoming you to.
Thank you very much, Dr. Tuishime. I think it's a very important topic in terms of also surgery to realize that we still are at risk of infection, be it ourselves or our patients. So it's really important to keep that in mind, as it seems sometimes that we might be a bit reckless, and therefore it is a good thing that RBC keeps track of everything. So we are now calling in the last session, and we'll be welcoming the moderators that have graced us with their presence. They are coming from the south and the north. I would like to welcome Dr. Munyaneza Robert from CHUB and Dr. Majambere from Butaro Hospital. Please welcome the moderators.
Thank you very much. As you can see, we are still having two panels, but we are merging them into one. So the two last panels will be into one. I'm taking this time to call upon Dr. Iradukunda Jules. He is a very young researcher, medical doctor, and also in charge of research, doing a lot of research in University of Global Health Equity. And he is very strong. He is going to present three papers, and he promised to present within 15 minutes. So all the papers are about education, and we are giving him the floor. Welcome, Dr. Iradukunda.
Good afternoon, everyone. I know it's not easy to talk to people after lunch, especially after these big speakers, but I will try to be as quick as possible because I have three presentations, and the good thing is they are somehow linked, and they are short and enjoyable. We skip the introductory slide because I've been introduced enough. I'm part of the UJH, which is the Burera University in the Northern Province. I'm going to be speaking about the medical surgical clerkship. It's our inaugural program. Just acknowledging the authors, and I don't have any conflict of interest to disclose. The first presentation is about designing a contextual friendly curriculum for surgical education. And even long before I joined medical school, most of the curriculum in surgery were copy and paste from curriculum from American universities, European universities. And yet we are training general practitioners and surgeons who will be practicing in hospitals in Rwanda mostly, and the majority of them are based in rural hospitals. So the aim of the research was to develop a curriculum that is friendly, contextualized, and that prepares general practitioners or medical students, general practitioners in training to practice in rural settings without any difficulty. And I give you an example. For some people who have been in the US, the epidemiology and the prevalence of the surgical conditions are different from the ones we have here. So it would be a shame if we train to, when we're making differential diagnosis, to start thinking as an American student. So we want to train them to think as Rwandan general practitioners or surgeons. We used, it's a combination of a Delphi method, which is one of the best way to generate consensus, and in combination of a focus group, which was done to triangulate or to confirm the findings of our research. So it was a 4-round Delphi, with the first round involving surgical educators, surgical experts, surgeons practicing in both Eastern and West African hospitals. We then came up with a list of procedures and topics to be included in the curriculum, then used 3 rounds to rate their inclusiveness, if do we include them as our Rwandan curriculum, or how, what is the priority we give to each of the topic. So the first round, as I said, it was an extensive literature study, which involved both gray literature and formal literature. We studied more than nearly 2,000 articles and 15 articles from gray literature. And as you can see, unfortunately, this projector is not clear enough. In the right corner, we have 2 screenshots of how we selected the papers. So this was done by a group of 7 researchers with 31 experts across East and West Africa, and we came up with 267 topics that were chosen as important for a surgical medical student. The second round, which the main question for the second round was, do we include this topic or not? So 92% of those topics were chosen to be included, and 12 of them, they had 100% consensus. This means that all the experts, all the educators rated those topics very important, and they wanted them to be included in the curriculum of a surgical medical student. Next. So our cut-off consensus rate was 75% acceptance to be included in the topic. So we also did, as you can see, a total of more than 240 topics were judged by 99.6% of the respondents as important in the curriculum. Next. Oh, this is a screenshot, but basically the first column is about the topics, and the second column is the response rate. Just for those who are in behind, the right corner, the right column is 100%. That was the initial round when we asked the experts, is this topic or this procedure essential in training a medical student to be a good general practitioner, to practice surgical procedures? Next. Same, 100%. Next. 100%, as I said, 99.6 procedures. One procedure, which is biliary duct injury, didn't meet the criteria. So as I said, the cutoff acceptance rate for topics to be included in the curriculum was 75%. And the one topic, which was in a group of hepatobiliary injuries, and specifically biliary duct injury, didn't meet the criteria. So it was excluded from the topics to move to the next round. So after that, as I said, it was a 4-round. The second round was to prioritize. So after you say this is part of the curriculum, then you would say, if we had 1 month, what are the main topics we could teach? Those are the ones that was rated 100%. So every expert chose, they rated those, they prioritized those topics and procedures, and we cut from 75% and above. So after that, since the aim was to create a curriculum that is specific to the Rwandan context, we invited a group of 40 participants, which includes surgical educators. Also, the Rwanda Surgical Society was also represented, general practitioners, and of course, the beneficiaries, medical interns and medical students. They were all brought together to elaborate one list, to kind of review the list we had came up with and say we agree on this or we disagree on this list. And if they had disagreed, we could have maybe done as a fifth round, but good enough. That's a list of everyone who attended, and I can see Dr. Mutabazi, Dr. Faustin, and so many other stakeholders. So lucky enough, the participants, including those that I just mentioned, they agreed on that list of topics, and we were happy that for once in the history of surgical training, we have a list that is not only specific to the African context, but a list that is specific to the Rwandan context. So this, to validate the findings of that literature review and the Delphi, as I said, we did a consensus conference. We took because we didn't want surgeons to influence students and students to feel like to feel afraid of discussing the topics they would want to see in their curriculum. So each group had its own focus group, and they discussed how they want the curriculum to look like, and all the focus groups were recorded and analyzed thematically to see if we captured everything from the discussion. And so the result, as you can see, we came up with curriculum content that was prioritized by both the African surgeon and the Rwandan surgeon. Next. So the discussion, briefly, Delphi was a good way to elaborate, to create consensus, because it's an iterative process. You keep asking people if they're really sure of their choices. And it was also good that we involved general practitioners, since they are the ones carrying out those surgical procedures. These are the references. I know it's not easy to summarize a 6 months research into 5 minutes, but questions are welcome after the last two presentations. Thank you so much. And as I said, this will be brief. This is a mixed method study. As you know, we recently, the first batch of medical students is graduating in 2025. So this was the inaugural clerkship. So we wanted to evaluate, see how best we did, and also to make sure we correct or evaluate ourselves. These are the co-authors. And no conflict of interest. And some of you can recall, maybe the older in the group, some of you might have studied in the classrooms under the tree. So our curriculum is designed to equip students not only with curriculum or paper or theoretical knowledge, but also to bring them back to the society to see the impact of surgical conditions, hernias, road traffic accidents, and so many other conditions. So this was, I'll spare the details, it was a 6 months clerkship with 32 faculties, as you can see. Next. So these are the methods we used. We first of all, as a wise man once said, there's nothing for us without us. So the moment you're designing a curriculum, a clerkship, a class, if you don't involve students, it will fail, because they are the beneficiaries. So we started student logbook. We did 2 qualitative, I would say, focus group, one with the faculty, another one with the students. We had also to learn from the lessons learned by the faculty, from their reflections. And also we did a paper-based survey with both the clinical staff that teach students on a daily basis, but also with the students. That's the questionnaire we used. The results, I'm afraid you can't see this, but I'm going to make sure you see it. More than 67% of the students said that, are you really able to read this? Okay, it's fine. My apologies for this. Overall evaluation of the program, students read more than 67% said that the clerkship was good, but unlike that, they said the operating volume was not good. And I remember when I was in medical school, it was enough. I don't know what changed, but I will come to it later. Then we also asked them if they would want the clerkship to remain at that training site, and 43% said yes. And another 13% said that they can think about it. So maybe they were confused. I don't know. But they say that we can think about it. This was a survey of both the clinical staff, nurses, general practitioners, surgeons who teach the student, and also the faculty. Because as I say, this is a two-way sword, so it has to be sharp at both sides. So the clinical staff say that they had good interactions with both the students and the faculty, which I have to emphasize on this. The moment the clinical staff fail or they don't like to teach the students, that's when the curriculum, no matter how good it is designed, it fails. So the program was rated as excellent or very good by 65.4 of the respondents. And here is the assessment we did. We grouped all the factors we learned from all those data collection methods. We grouped them into enhancers and or barriers, enhancers and barriers. The enhancers is one of the key success of a good clerkship is to have a strong collaborative relationship between the clinical staff but also the university staff. Another enhancer is the motivation of the staff to engage with teaching. This point, I come back to it during the recommendation. Most of the clinical staff say they needed motivation. So we're not really sure if the motivation is money, monetary motivation, academic motivation, or any other form of motivation. But it was noted by many of the stakeholders that if they had motivation, things would go a little better. The barriers, one of them is the staff has a workload, and this is not new to anyone in this room. So they are busy. They don't really have time to concentrate to teaching. Another is there's low volume of both of surgical cases. As you know, Butaro Hospital is mainly cancer-centric. So this is also understandable. And the infrastructure challenge, as also you know, we sometimes have challenges with the district hospitals. They run out of sutures, anesthesia drugs, and a lot of logistics we cannot control as academicians. But of all the discussions we had, 4 themes arose: teaching and learning, which was the main aim of the clerkship; patient care. The patient care was mainly brought up by the clinical staff, who said that although they didn't have time to teach the students, but they were able to spare some time because the students were also contributing to patient care. So, and I know we used to run to the lab to take lab results, and we record that we assisted in a hysterosalpingo-oophorectomy, and yet we just ran to collect lab results for an obstetrician. And also the clinical exposure, we have to ensure that students not only attend the hospital, but they also have to see things. That's how they learn. And also working support and clerkship organization. I can't go in details for the sake of time, but when the clerkship is chaotic, learning also becomes chaotic. The conclusion, district hospitals have been so far disregarded as potential clinical teaching sites, but from our first cohort, we can say that they can still be potential teaching sites. And also, this clerkship was well received by both the surgeons, both the clinical faculty, and also the UGHE faculty. This is also aimed, helped us to discover or to unearth some of the barriers to having our students learn in an effective and teaching-friendly environment. Thank you. Questions? Maybe after. You can clap. Thank you, Dr. George. My last presentation. I'm sorry, I'm feeding a lot of details, but I have to do this. Then after all the data collections we did, we developed a framework which we think it's a potential tool to enhance or to facilitate surgical training in the undergraduate training. Same disclosure. This is again about the program. You can skip this. I said about it. This was also, the framework was a result of a mixed method research design. Unlike the previous presentation, it includes both qualitative methods, and also we also used some of the SWOT analysis. We also used contextual framework analysis technique. The aim of this, we wanted to see how can we, what is the guidance we can use to effectively provide undergraduate surgical training to our medical students. Next. You cannot read this, but I'm going to make it easier for you. So the strength of a curriculum, as some of you, even all the elders know, surgery is no longer something, is no longer in the OR. You are training global medical students, global surgeons. So we used a hybrid delivery clerkship whereby we had both online faculty and in-person faculty in order to ensure that, of course, we have a contextualized curriculum, but also to ensure that they don't have this narrow point of view in terms of surgery. So we have to ensure that they are contextual, the knowledge is contextualized, but also they are global surgeons and global medical students. So we used a hybrid delivery. We also used simulations. As you know, with these patients, advocates, it's getting hard for medical students to learn some of the practical skills Dr. George and the elders used to learn back in medical school. So we moved towards using simulation-based teaching. And the last one is about bidirectional partnership. As Paul Farmer used to say, that most of our achievements will come from working with others, or in a word, partnerships. Partnership includes University of Rwanda partnering with CHUK, CHUB, UGHE, AUCA, and this is how we train students to be not only to be surgeons, but also to be open to the external world, not just in the OR or within the hospital. The scope of improvement, as students suggested in my previous research, the case mix, as Dr. Majambel can testify, most of our cases are oncological cases, breast cancer especially. So if there is a case mix, different cases, but of course in high volume, because as you know, surgery is art. The more you practice, the more you better your skills. And also supervision faculty, and I can testify to this. While I was at the University of Rwanda, I sometimes felt lost in a jungle of a hospital. So supervision, and for this I mean close supervision, evaluation, hearing what the students have to say and learn from them to improve the curriculum. You cannot see this, and you cannot see. This is a table that summarizes the whole framework, and it's unfortunate that you can't see it, but it's briefly grouped into, I think, 17 points that explains the best way, not the best way, because we are still upgrading, but the best way to shape an undergraduate surgical clerkship. Next. So the discussion, as I said, the aim of this research was to generate Rwandan-based knowledge about undergraduate training. And what helps is, as I said, a sufficient case mix, case volume, and also surgical infrastructures, because these ups and downs in medical supplies also kind of jeopardizes or risks, puts in risk surgical training, both undergraduate and postgraduate. So thank you so much. I hope I was not boring. And questions, complaints, and compliments are welcome. Thank you.
Thank you, Dr. Gilles, for keeping in time. I'm calling upon Dr. Christophe to present about the assessment of hospital readiness in implementing a nurse training program. So Dr. Christophe is a consultant general surgeon with experience in research and training.
Thank you, moderator. I'm going to present a title called the study results of a study called Assessment of Hospital Readiness in Implementing NOT course. As you know, in a few years back, almost 4 years back, Rwanda Surgical Society conducted a non-technical skills for surgeons in different teaching hospitals, which aimed at training healthcare providers on non-technical skills. And during those trainings, you have seen the people who have been trained have shown interest in the course and wished that the course can be delivered to more healthcare providers. And we trained a lot of different people, and afterwards people were practicing, putting into practice the skills, non-technical skills that they gained during that course. So recently we had an idea of doing kind of monitoring and evaluation and see whether the course is still important to surgical healthcare providers, and also see whether this course can be integrated in quality improvement projects of different hospitals. This project was implemented through a partnership between Rwanda Surgical Society, Ministry of Health, and the Program for Global Social Change at Harvard University and Safe Surgery Program. NOT courses are essential for safe intraoperative patient care, and this NOT care has been developed and taught to surgical care providers in Rwanda, and the outcome was that more people needed to be taught get this course. So we have gathered information to see whether this course can be delivered to more surgical care providers, and we wanted to evaluate the perception of surgical team members and hospital leadership on the feasibility of integrating this course into their regular quality improvement project. So we have used a surgical care provider, paper-based safe surgery organizational readiness tool. It is a tool that has 6 domains, and each domain
testing the readiness, and we have conducted the NOT course at 11 hospitals, and after 2 hours course for health professionals, we have administered this data collection tool to hear their perspectives, and after those domains, they have scores which are dichotomized, and they are regarded from if you ugly, whether as strong, ugly to all domains, or they are neutral, or you disagree with the enunciate, and then after we have done multivariate regression to see to assess the relationship between the participant and the hospital characteristics in regards to the 6 domains. The result we had that the respondents, we had around 52 were female, and the students were around 24%, and the doctors were around 10%. With work experience, majority we had around 67 months, and the facility we did training in this hospital, provincial, and teaching hospitals. The institutional readiness in implementing this course, we have seen that the facility capacity, psychological safety, and resistance to change were some elements that were scoring low compared to other elements. And what we've seen is that people who are more experienced, they don't feel that there is any change whenever there is something new in their working environment. And this is a very important findings that we need really to take into account when it comes to change, whether in a different practice. For example, some of the clinical trials we've presented, they are like the sheet where we said we need a change, but we need to understand that this course have shown that people who have more experience, they are really resistant to change. And if we need to start implementing change, we should start from those new ones. So the new employees, and during their orientation, there should be also taught this NOT course, but also other new evidence-based. They are the ones who should be taught first, and then once they join the clinical practice, they will be maybe the more model or help to change those with a long experience. And also, doctors reported more individual efficacy compared to other clinical settings. Anesthesia providers were more likely to resist to change. And also, participants from provincial hospitals don't feel safe to take the risk. This is what the study have shown. And as a conclusion, you have seen that this study revealed that the domains that seem most challenging were psychological safety and resistance to change. And the hospital leadership should create a safe environment for employees to learn and grow. And this should mainly start from the new employees. Then once the new employees understand, it will be easier also to change those who are staying in the service for a long time. We have also the findings also from this study help us to design and pilot this NOT training program to address the hospital-specific problems, because the problems of hospitals differs according to their level. The problems from districts are different from the teaching and the level of hospitals. It's better to also take into account the level of the facility while trying to implement this course
as you have seen that it helps to improve patient safety. To be a good surgeon, you need surgical skills, but on the other hand, you also need non-technical skills to help you put into practice your surgical skills. Thank you.
Thank you, Dr. Milimbanyi. I am calling upon Dr. Uwizeimana Eugene. Dr. Uwizeimana is an orthopedic surgeon. He just completed his 5 years training last week. Yes. So he's going to present about assessment of preventable causes and the predictors of independent ambulation for cerebral palsy in Rwanda. Welcome, Doctor.
Okay, thank you. Good afternoon again. As I said, I'm a junior orthopedic surgeon. I'm going to present on the assessment of preventable causes and the predictors of independent ambulation for children with cerebral palsy in Rwanda. So this work was supervised by Prof. John Ibjimana and Dr. Albert Nzaisenga. So as introduction, so the cerebral palsy, as all of we know, is a group of disorders which affecting the movement and the posture, and this causes activity restriction, and it was attributable to non-progressive injury to immature brain, and this will cause progressive motor disability. So it is the most common cause of childhood disability worldwide, and as a prevalence in low middle income countries like in Uganda and Egypt, so the prevalence is slightly different when you compare the high income countries and the poor countries. And this condition, so it's burdening to orthopedic practice, not only on the orthopedic practice, even to parents, even in a country. Some studies showed more than 50% they will need at least one orthopedic procedure during their life. So in this condition, in Rwanda, so at what I researched, there is no published research done. So this is the first one. So others were done in general on the disabilities, but specifically for cerebral palsy, there was no paper published. So the objectives, the first one was to identify the preventable causes and risk factors, and to describe the mode of treatment given to this patient in the hospital where this study was conducted. The third one is to identify the predictors of independent ambulation in cerebral palsy patient, because more the patient will receive, every parent will ask you if you see if the child will be able to work, will be able to participate in basic daily activities. So, as I said, this study was conducted in specialized hospital, Ririma. So it is in 50 kilometers from here, and it is a retrospective observational study. We recruited patients which are clinically diagnosis confirmed with the range of 2 to 18 years, which followed at this hospital. So the sample size, we used the Andrew Fisher formula, which estimated around 385 patients. So the analysis, we used SPSS univariate analysis and Chi-square and the logistic regression were used to identify the relationship between the findings and the ambulation ability. So concerning the results, we recruited around 395 patients, where the male were 53% and the female they are 60%. We see that there is no significant difference between in gender, and the median age of consultation was around 4 years of age. So the most common factors we found that fetal distress was represented in 27.6%, low birth weight about 20.5%, and the congenital malformation was presented in 13.6%, and the prematurity was around 8.9. So the mode of treatment we do at this hospital, so it means it is the non-operative management and operative management. But the non-operative management, including occupational therapy and physiotherapy, was the most common modality used to treat our patient, where the surgical procedures, they are not really significant presented. So the predictors of ambulation, we found that when the child is able to sit before 2 years, it is a good predictor of that child will be able to work in coming years. And the motor severity, that means the ability of moving, and also the part of the body which are affected, like if it is a hemiplegia or quadriplegia, those they are predicting the ambulation. So if the child also has no problem of intellectual, and if there are no problem of blindness or epilepsy, it is the good indicators. So about the discussion, as you have seen, we found that our patients, they are delaying to consult. So this is the same in lower, in poor countries. And in high-income countries, they even able to make a diagnosis at the 6 months of age. So many factors, many causes we found in term babies. We have seen prematurity represented in 8.9. So this is the same in low-income countries, but in high-income countries, because of the good equipment for caring to premature, actually they have premature baby which has this condition of cerebral palsy. So as a conclusion, as we found, the majority of our children, they are term babies, and the many risk factors we found, they are preventable. So to establish the preventive management, it is a highly recommended. So those are the recommendation to health facilities, to Ministry of Health, to facilitate the access and the medical surgical care, as this is. So we know that even in our community, we can find many children who are not able to consult. So if we have some organization to help those children, it will be good for the outcome. And for the future researchers, we need to conduct a nationwide population-based study to know really the trend of the prevalence of our children, the prevalence of cerebral palsy. So this is the end of my presentation. Thank you very much.
Thank you, Dr. Jean, for the presentation. Keeping all questions after the last presentation for this session, which is the last. I'm calling upon the last presenter. Mutoni Clemens. Mutoni Clemens is going to present on occipital encephalocele not covered with skin in a newborn at Seashka. So Mutoni Clement is first year surgical trainee in neurology. So we have much interest in doing research and developing it. The floor is yours.
Thank you. Good afternoon, everyone. My presentation is about a neurosurgical case report of an uncovered occipital meningoencephalocele in a newborn at Seashka. We've been working together with Dr. Muneza, Dr. Inyange Sylvie, and Dr. Honsi Deogracias. So as an introduction, an encephalocele is a congenital malformation of the neurotube defect where the sac containing the intracranial contents are out of the skull. And it is divided into different types according to the location and to the protruded part, where on the image you can see the meningoencephalocele where there is brain herniation. With the meningocele there is meninges, protrusion, and meningohydrocephalus. So neurotube defects are the second most anomalies in children, secondary to heart defects, and its incidence is around 1 over 1,000 live births worldwide. And the encephalocele accounts for about 15 to 20%, where the occipital encephalocele is the most common, with 70%. And it is most prevalent in female compared to male, with a 70%. And the prenatal ultrasound scan is sensitive to about 80%. And the prognosis depends on the affected intracranial structures, where the mortality is about 80%. So the treatment option for the encephalocele is a surgical treatment or surgical intervention, where it should be done between birth to 4 months. But when there is a skin covering the brain structure, it can be delayed for some few months. However, if there's no skin, it should be an emergency. It should be, the surgery should be done as quickly as possible. So as a reminder, we are talking of occipital meningoencephalocele not covered with skin, but partially covered by a thin membrane. So this was a case that we admitted at Seashka. The patient was day 1 of life, was a female she was born at the health center by spontaneous vaginal delivery with an APGAR of 7, 8, and 10, where she needed a mild resuscitation, which was performed by the midwife at the health center. So she presented at the hospital complaining of, the mother was complaining of a bulging mass on the occipital part of the head of the baby. And going back to the maternal history, this was her second pregnancy. However, the previous pregnancy was really normal with no problem. And on this pregnancy, there was no chronic diseases. She didn't get folic acid supplement, and there was no antenatal scan performed. So on the physical exam of the newborn, the baby had normal vital signs with normal reflexes, however had microcephaly and a depressed fontanelle, with no signs of hydrocephalus or raised ICP. The occipital mass was measuring around 8 cross 10 centimeter, and it was intact with no skin coverage. It was normothermic, firm, with smooth edges. So on the brain CT scan performed at the hospital, it has revealed a brain ventricles herniation in the sac, and we opted to do the non-operable management as we expected to have a very high mortality, or we had a very bad prognosis. So we did patient education and counseling, which was really hard. So as a conclusion, we recommended a systematic antenatal ultrasound scan screening to pregnant women, and implementation of preventive, like with giving folic acid supplement, and to increase awareness in the community about neurotube defects, as the mother was not understanding well what was going on with the baby, and a multidisciplinary approach, as we've seen that a prenatal, the ultrasound scan can reveal this encephalocele. We should work hand in hand with other disciplinaries like gynecology. So thank you for your kind attention, and this was my references.
Thank you. It's really encouraging to see such a young doctor resident being into research as a earlier stage. So this is the time for comments or questions. We are going to welcome maximum 3. And maybe my question goes to Dr. Radukunda. Are your papers published, and where can we find your results?
Thank you. We are working on the manuscript, and we aim to publish them in open access papers so that we can it can be reached by as many readers as possible.
Any other question?
Yes. My question goes to Dr. Eugene. So I was somehow concerned about the study. So you mentioned that the study was conducted on one hospital. So here I go with the sample representativity, because you are giving recommendations at the national level, so which I don't think will be like a good mechanism. So the other one is about the so in this it goes in the same line with the generalizability of the study. So the results from one, how can we generalize this study across the entire country? The third one is about risk factor and confounders in that you considered in the analysis. So how do you distinguish risk factors to confounders?
Okay, thank you. For the first question, as I said, the study was conducted in the one hospital, of course. So the Ridima Hospital is a specialized hospital for children. So it covers the whole country, and I think here in Rwanda we have other centers which caring for those disabled children, but the Ririma Hospital has orthopedic surgeon and it has the physiotherapist. So it is where the children can get operative and non-operative management. So it covers the whole country. So it is good to present what is done for the cerebral palsy patient in the country. So if you get an answer, I think you can repeat again for the second question. Thank you.
The second question was about the distinction between risk factors and the confounders in your study.
Okay, thank you. So for this condition, so actually there is not. The cause, they are multifactorial. So they are not really definition for the causes. So actually it is put together in the risk factors. But for the confounders, I think the audience can help. I don't know the meaning of confounders, but what I say on the risk factors and the causes, we put it together, the risk factors and the causes. Yeah.
You will give us the definition, but we will see the difference.
Okay, yeah, I can help. The confounders, I mean the factors which affect at the same time the outcome and the risk factors.
Is there more questions? Or we can hand over.
Thank you, the presenters. I'm Rwamba Jean Paul. I finished my residence general surgery 1 week back, as they have been saying. So my question goes to thank you. So my question goes to Gilles Iladukunda. So Dr. Gilles has been presenting about to try to make curriculum according to our settings. But from what I heard from Prof. Faustin is that when they are training us, and that's what I agree on, is that they train a local, a regional, and an international doctor. Because, try to tell us more about your curriculum you are designing. You are trying to make it as training of a local doctor. But what is your say about training of a competent general surgeon who is dealing with local things in our settings, dealing with the regional, and being an international? Because at the end of the day, will it be an international doctor? That's the aim of our trainers. So you are designing a program, a curriculum, which is trying to make things so that we deal with our own conditions. But definitely will not be set only here. Will it be, I have to think out of the box. So what is your say about it? Thank you.
Thank you so much, Doctor. And by the way, congratulations. I know you used to be my teacher, so I respect you. So I go straight to your question. I'm not saying that we are bringing something new, but my claim is education is a dynamic initiative. So I know we were trained in a good way, but it doesn't mean we cannot update the knowledge. So that's the first message. And the second message is, the aim is to train a global doctor. But as it's said in Kinyarwanda, ija kurishera kurugo. I would want you to be very conversant with the local knowledge, with the people you see every day, before you be very conversant with the epidemiology of Nigeria or the American, because we might not, all of us might not be in America, but I'm sure that we will practice initially in Rwanda, and if God blesses us with the opportunity, we can still go to America. So the claim is not to be a narrow trained surgeon. It is to build on the local knowledge to become a global citizen. And it doesn't really, and what we want to emphasize is equity in global surgery. We've been fed by American textbooks that American education is the best, but also African education can be the best if researched, published, and advertised. Thank you.
So, thank you everyone who has presented for this panel. We are handing over the floor to the MC. Thank you very much.
Thank you very much. Another round of applause for the moderators and the good discussion that we have. We are about to finish. We are almost at the end. We would like to welcome you for a small tea break of about 10 minutes, and then we'll welcome you back to wrap up the whole conference. We'll have then the closing remarks by the surgical chair. Thank you again. So it's on the other side, just on your right. Thanks.
We've done great, huh? We even have 10 minutes to spare, having it delayed in the morning, huh? That's great.
Hello, hello. Good afternoon once more. Hello, hello. Good afternoon. Once more, please, please go back to your seats. So we are now at the end of the conference. Yes. And so we wanted to do a small wrap-up. Hello, hello. For the ones that are still outside, please come in. And the ones in the back also, please have a seat. Yes. Thank you. So as I was saying, we are now at the end of our scientific conference organized by the Rwanda Surgical Society. I am also happy to say that we still have some scholarship for time management and clapping, and I hope that some of you will try and join me in that new PhD. I would like to welcome Dr. Nathalie to wrap up quickly and give us the main points that were discussed throughout during this interesting conference with many discussion. And I think she will take, she was already presented before, so without further ado, I'm giving her the floor.
Thank you for giving me the floor to share the minutes of this presentation. So the team, we were a team on that table. We were working closely on writing the minutes, and I acknowledge everyone on that team. And also I acknowledge Mr. Uwimbabazi, who was streaming live the minutes on the Rwanda Surgical Society website. So if anyone wants to see what was discussed and the main points, you can log in on the website, and everything has been displayed. So next slide. So we started by a welcome note by Prof. Musi, the president of Rwanda Surgical Society. Then we heard opening remarks by our guest of honor, Dr. Patrick Ndimobanzi, where he emphasized on the limited workforce, surgical workforce in the country, and highlighted the challenges, and then told us how the HRH program at the Ministry of Health is working hard to strengthening training programs that are already in place, and also to introduce new programs, and ensured the utmost collaboration and partnership from the Ministry of Health. So we entered into panel sessions. We started by the surgical education in Rwanda, an overview where we followed the historical background of surgical training in Rwanda, and there was an emphasis on the importance of local training as the most efficient way to address the gap of surgical workforce in the country and also in the region. So we had an overview of the surgical training at the University of Rwanda, where we heard the different opportunities that are available, but also the challenges. And in opportunities, we heard that there are many programs that are ongoing, but also programs that are planned for the future, such as subspecialties, including vascular surgery, cardiothoracic surgery, to name a few. We also saw that there is an importance to emphasize on teaching and calling everyone to be involved in teaching, making every surgical case an opportunity for teaching, but also to emphasize on the quality of training. We heard about surgical training through the COSEXA program, the requirements, the training curriculum, but also the different opportunities that are in the COSEXA program. We heard the importance of ensuring surgical training starting from the undergraduate students and undergraduate education, how important it is to design policies and curriculums that are tailored to the low and middle income settings, needs and resources, the importance of task sharing for improving surgical care rather than task shifting, and there was a discussion about how it is needed to rethink about the training curriculum of surgeon that emphasize on basic surgical principles and skills before joining the different subspecialties. The other session was on surgical training in Rwanda, where we heard from different perspectives, including the Ministry of Health, including the University of Rwanda, including the different surgical training programs, but also including experience from trainees, and recommendations were given. Some of them include strengthening surgical system and capacity building at the level of the Ministry of Health in collaboration with the University of Rwanda and the University of Rwanda and different hospitals, but also empowering research activities during surgical education. We heard a panel on evidence-based surgical practice. There were very interesting clinical trials that were presented and very interesting findings. One of them is how change of surgical gloves and instruments prior to abdominal closure reduces surgical site infection in abdominal surgeries. And this can should be included in clinical guidelines because it is a cost-effective way to address the burden of surgical site infections. So there were other clinical trials, and we will find the detailed results in the detailed minutes. So we heard also on the panel on surgical practice and COVID-19 pandemic, and there was an impact on surgical care during the pandemic, but we saw that overall the system was resilient. Then there were multiple free papers which were all focusing on surgical education. There were those that were focusing on undergraduate student surgical education, resident and surgical staff, but also on raising public awareness on various surgical diseases. Thank you all. That was the summary of today's presentations. Thank you.
Thank you very much, Dr. Nathalie, for the nice summary. I would like again to thank again the whole team that took the minutes and gave us a good overview of the whole conference. I would like to thank you all. This would be my last comments or my last apparition of the night. And I would like to hope that you will be staying with new solutions or maybe solutions that you had already starting to set up so that surgical education can become even better in Rwanda, and while also remembering to focus on the mentees, the surgical trainees, and the undergraduate students mostly. In finishing, I would like to welcome once again the chair of the Rwanda Surgical Society to give the closing remarks. And I thank you once again. Good evening.
Thank you very much. He called himself the clapper. Thank you very much. I'm not yet giving closing remarks. We supposed to talk about the recommendations. We've got the minutes. So what do you take? Maybe 5 people giving us what the recommendations we can ask people the high, let's say 5 recommendations from here. We can take that and write it in minutes. The recommendations that we can take, and then we'll ask the chair our chair at the University of Rwanda to chair of surgery to close for us. After we give some recommendations. We're not very behind. You know, all of us had thought it will be 7. Now we are 5. So 5:30 we should be leaving here. So we've done a good job. Let's give some recommendations. Now I'm going to be a dictator. If you don't put your arms up, I'll be saying volunteer you. But at least we have some people, some arms up.
Mine would be to strengthen mentorship in surgical residence.
Clear? Next.
Thank you very much. My recommendation is to do structured mentorship as early as possible in the medical student, and also to involve us through your research. Thank you.
Thank you very much. I think my recommendation is same as my colleague, because 90% of students join medicine while interested in surgery, but at one point, at certain degree, they lose interest. And I think increasing early exposure and not just waiting for students to reach in level 3 or in level 4, and trying early exposure will help students remain interested in surgery and will increase the surgical workforce. Thank you.
Thank you. I have one recommendation as well. So mine is as we are addressing the surgical capacity, so we have to be holistic, and the human resource part of it that we are working on from the education standpoint should be done parallel to other components. Means working on the infrastructure part, equipment, supplies, so that when we send surgeons in referral district hospitals, they feel comfortable when to do surgery, so that we don't lose them as they are there and maybe end up by losing skills.
So, Chair, you mean, because I want them to write, so I think they are looking at the way of writing it. So you say you recommend that we look at other components of education.
Other components of capacity building. Because capacity building is not human resource only. It's a holistic thing. So it includes infrastructure and equipment, so that we can, at the end, offer surgery.
Thank you, Chair. My recommendation is that we have, as Rwanda Surgical Society, we should have put in place an outreach program to decrease the backlog of cases that has been left behind by this COVID pandemic. Whether we do it on quarterly basis, but as a society we have to put in place that outreach and own it. That will be led by Rwanda Surgical Society.
My recommendation is, as we are talking about evidence-based surgical practice, it's to encourage the younger generation of surgeons to join clinical trials and not stay on observational studies. Move to clinical trials, or join the team for clinical trials.
More? I can see a number there.
So based on the experience we had with the hub in our last symposium, so I think it would be better to just to conduct a kind of survey, so feedback survey, just like to know what everyone is thinking or what should be like the feedback from this conference.
Another one? So we just need more three and we...
Thank you. Another one would be to think about the way we could have a Rwanda Surgical Journal in the future. Thank you. Rwanda Surgical Journal.
Yeah, we had. I'm just looking at the complexities, but it's a recommendation. Two more. Somebody was talking about finding out what is causing, to find out the reasons for decreasing or low participation of surgeons in the society.
Thank you. My recommendation is that I'm called Dr. James. I work as a GP, new GP at Ruamagana Provincial Hospital. I recommend the different surgeons just to make outreaches to different hospitals, especially district hospital, just to motivate or to sensitize different GPs to join surgical residency. Thank you. I think the other one would be like to, in terms of research wise, so it would be better if surgeons keep building partnership with the other people from other fields, scientific fields. So like more statisticians, for example, be involved in research. So that one will be help to improve our results. Also, this also will improve our recommendations. So because sometimes you interpret the interpretation of results or interpretation of data should be what can I say? Should be given a valid maybe policy.
Thank you, Chair. I think you alluded to me, so let me make it a bit clear. So they say that it takes a village to raise a child in Africa. So it takes the whole village. Our village is a bit empty. The elder villagers are not visible in the village. So the children are going to have trouble there. So it goes back to the mentorship and the rest. So we suggested that we could create an ad hoc committee to brainstorm around this question of desertion and apathy. And from there, we'll work on the solutions to address this, because those needs that are there for mentorship and training, they will be addressed by the village to come back together. Thank you.
Thank you, Chair. Another recommendation I would suggest goes with what the guest of honor talked about, and training different specialties. We should conduct a survey and see what are the gaps, current gaps we are meeting with in surgical training. I mean, we should see the different surgical specialties, what are the challenges, and also we also make the same survey to those in in the training and those who have finished the training. And we compare both groups and see where are the challenges, and to help us to know how we should also redesign the curriculum, especially for the first basic sciences in the surgical residence.
Thank you very much, all of you. It looks like ideas are coming slowly by slowly, but in summary, what I've understood, there are three components. One, we need to make strategies for mentorship. Two is to form an ad hoc committee that is going to look into that. Three is that our village is emptying or has never been full. We need to fill it. But all of them go with one thing. So the ad hoc committee can address all the recommendations, and by the time we meet the mini AGM, then the setting the agenda, we should have concrete solutions that we suggest, so that in the next meeting, that committee will present that, and then in the meeting we'll give solutions, we'll find solutions. That takes us to the next step of the committee, ad hoc committee. Because you cannot form an ad hoc committee of people that are not here. So ad hoc committee does not require any legalities, so we can choose people that are here, that are representative across. My suggestion is that we put at least a representative of students, representative of residents, and of course, adding to the executive committee some more, maybe 2 people. That 5 people, 6 people should be enough in that ad hoc committee. Okay, so not to take a lot of time, we have executive committee that is represented. All of us are here, so we need to get one resident. One resident, can you quickly, amongst yourselves, choose a resident that can join us? If female, even better. If female is better, choose a female resident. Mwamwumvise? Brandon. From the side of students? Yes, you're proposing? Very good. Verite? Okay. Where is, so we have got students, residents. The executive committee is here. From surgery, we can incorporate you. So we incorporate Prof. Foste from surgery department, and education is done. We need somebody from COSEXA. No. There are 2 representatives from COSEXA. We are overfilling. Let's not add another one. I think that's enough. Yes, you wanted somebody? Okay. Okay. Who's here? The younger group, eh? Okay, Robert. Robert is intermediate. But it is easy for him to interact and figure out what's going on. Okay, so Robert is incorporated. Thank you very much. I think this is among the most fruitful meetings that we've had. Previously, yes, we discussed data. We've been actually having high caliber presentations. And when we talked about education, all of us were worried. But what has come out? I mean, it's unbelievable. So education is what brought us here, and education we are getting. Now it's time for the closure, and I invite our chair to close for us. Thank you very much.
Good afternoon, everyone. Again, thank you, President of Rwanda Surgical Society, for giving me the floor and the opportunity to close this important conference. So, surgical education and evidence-based are two. Actually, it's one, because we cannot teach when you don't do research, because this research is there to inform what we teach, and actually, at the end of the day, to change and influence what we do as professionals. So this day was really a very good day, and for those who know me, they know that I'm happy when we sit and discuss and hear you presenting this kind of breaking field kind of research. So it was an honor to have you, all of you, from the morning till now. I'm not going to take long of your time. So on behalf of the Department of Surgery, University of Rwanda, and from the Dean of the School of Medicine, who apologized for leaving a little bit earlier because of another conflicting agenda. So we thank you, and we commit that we are going to move this forward, and hope that we are meeting here again next year, sometime a few months from now. And next time, I hope the village will be very full. And then we're gonna again discuss this kind of findings and improve what we are doing. So congratulations to all of you, those who presented, and those who had research in the pipeline that we'll be listening to next time. Please continue working on that. So there are support all over. So those needing support, we can help. So we have different capacities, from statistics to epidemiology to clinical trials. We can support in different things. So thank you very much. And on this note, I declare this conference closed. Thank you.